السلام عليكم. نبدأ إن شاء الله عشان الوقت. Bismillah ar-Rahman ar-Rahim. Today, inshallah, the subspecialty lecture will be about inherited retinal disorders. In fact, I spoke to the Chief President, Muhammad, and he chose the topic after discussing with yourselves, because I believe you thought that the retinal dystrophies, is one of the areas that you are not very familiar with, and you would like to get, a bit closer. It's a big topic, of course, so we cannot do everything today. So, inshallah, the plan will be to just take like a general orientation, how we deal with a case of dystrophy in general. And then we will take some, of the famous examples of photoreceptors dystrophies, because we cannot cover everything today. Inshallah, we'll touch on, what we do nowadays, what is available, what is expected to be available soon, and what's coming after that. Of course, there are a big amount of details in the field. We will not cover everything, as I say. Just will try to get you closer to what's happening nowadays, okay? So if we speak about the inherited fundus disorders, we can classify them in many ways. Just one simple way is to go in an anatomical way, starting from the vitreous, going deeper towards the choroid. So we can divide them into, for example, hereditary vitreoretinopathies. Any examples? Can you give any example? Stickler disease, yes. Fever, familial exudative vitreoretinopathy. Or inner retinal dystrophies affecting the inner retina, such as, for example, X-linked retinoschisis, for example, or congenital stationary night blindness. Or it could be photoreceptors dystrophies affecting the layer of the photoreceptors. We'll touch on that today. Or RPE dystrophies affecting the RPE layer, or choroidal dystrophies. There are many ways of classification, but you can simply classify it like this. So how do we assess a case of retinal dystrophy when we see these cases in the clinic? We follow the normal steps with, some special considerations that, are of relative importance in cases of the inherited disorders. Number one, we take history, as always. Then we proceed to clinical examination. Then we do some imaging that helps us. And we do electrophysiology testing, and we do genetic testing. I'm glad that Lynn and Alka just joined, because they will help us today, inshallah. First is history. When you take history from any patients attending the eye clinic to you, what is the first thing you ask about? Symptoms, isn't it? What is the problem? What's wrong with you? And in cases like, for example, cataract or diabetic macular edema, it could be enough just to know that the vision is reduced for some period of time and, for example, getting worse over time. That could be enough, as I say, in regular cases. But in cases of dystrophies, this is not enough, in fact. We need to ask specific questions. And these specific questions give us very important information to evaluate the case. And you will be surprised that I and many people, just after taking a history, are almost there with diagnosis, just with history. You know what's going wrong. Then we proceed with all the assessment tools just to confirm and have a baseline assessment against which we will compare in the future. So, number one, we need to ask about night vision, like vision in dim illumination. We ask the patient specific, do you have a problem with the vision or not? And the other way around, do you have a problem with bright light or not? This has, of course, relative importance. And do you have difficulty on moving from light to dark or dark to light? Because this gives us an idea about the dark adaptation and light adaptation. Do you have problems with seeing colors? The age of onset of the problem. In fact, in the Saudi patients, it's very difficult to get the answer to this question. But you keep at least to get an idea close to what happened. So usually they say, I'm not sure, it happened years ago. But what I do is, was it at school age, before school, after school? Just to get at least an approximation, if it's not very accurate. And the course of the disease, is it stationary? So it happened like this and remained like this all the time, or progressing? Because some diseases are like this and some diseases are like that. And we need to ask about family history. This is very important in cases of dystrophies. Number one, consanguinity, which is very common here in Saudi Arabia. And most of the cases, in fact, we see in the clinics are autosomal recessive because of the marriage among relatives here, which is, I think, a very cultural thing in the community. Affected members, how many members of the family are affected? This again adds some information to us to understand the mode of inheritance. And we draw the family pedigree. We need also to ask about the medical history because this helps us to differentiate between syndromic versus non-syndromic cases. Because non-syndromic when the problem is only with the eye, syndromic when it has other medical associations. So that's the history briefly. Then we proceed to the examination. In the examination, we need ocular examination, of course. We start by vision, and preferably we get color vision also. We look for nystagmus, especially in children. We check the anterior segment, and keep in mind, most of the inherited cases we see here in the dystrophy clinics are retinitis pigmentosa. And in a quite substantial portion of these patients, they have posterior subcapsular cataracts. So look for it, because if you don't look for it, you might miss it. Check the vitreous, because in many dystrophies there are associated vitreal changes. The optic discs, the retinal vessels, the retina itself, especially if there is intraretinal pigment migration, which people call point spicules, retinal pigment epithelium, and the choroid. Then we have a general check. General signs here, I don't mean by this what the general physician would do, because if needed, we refer them to the general physician or the pediatrician to check what is there if we suspect systemic associations. But here I mean anything that is like striking to attract your attention. For example, deafness or hearing aid. If you're speaking to the patient and they cannot hear you, so what comes to your mind? For example, and we have the Usher experts sitting here. Extra digits, if they have extra digit. Obesity, we see this in the Bardet-Biedl syndrome, for example. Any dysmorphic features that gives you a suspicion that the condition might be syndromic. Or sunken eyes, for example. If it's a little child with no vision and sunken eyes, what comes to your mind? Livers, exactly, yes. So again, this is briefly how we proceed with the examination. Then we move to imaging. We have, in practice, what we do nowadays, three pretty simple things. Number one, we need to get color photos. Even if you know the diagnosis straight away, we need to document, at least at baseline, the changes that are there. Because this patient will be with us for years, and the disease will, evolve as time goes, and many changes will take place. So we need to compare to this later on to see what happened with the clinical picture. Even if they come to another doctor in many years, he can compare to that, and that helps out. Number two, which is very, very, very useful, is the fundus autofluorescence. In fact, if you tell me what is the most helpful imaging modality in dystrophies, I would say it's fundus autofluorescence. It gives us very, very useful information. The fundus autofluorescence simply can be, the imaging is done. There are many wavelengths that could be used. The first one is the standard, which is the blue light, 488 nanometers. It gives us an idea about the lipofuscin, which reflects the state of health of the retinal pigment epithelium. So if there are areas of loss, it appears as dark areas. And if there are areas of high signal, it means there is metabolic overload happening in the retinal pigment epithelium, and you predict this will degenerate soon and will undergo atrophy. So this is with the conventional way, which we have here. There is even a better way called near-infrared autofluorescence. Unfortunately, we don't have it in KKESH at the moment. Have been trying to get a new machine, but not yet successful. And this reflects the changes before the conventional way of imaging shows the changes. So it's really useful to show the early changes before the damage takes place. And this, of course, has implication about the therapeutic options that we will discuss shortly. The third one is OCT. And OCT, as we all know, is good to show the structure. We need to know the structure, what's happening structurally there in this affected eye. Number one, we assess the integrity of layers, like, for example, the retinal pigment epithelium, the photoreceptor layers, and the other layers as well. We measure the retinal thickness, and we detect or document cystic spaces. Sometimes they are really tiny. You cannot detect them clinically. Abdullah is working with me now, and he knows how to see the cystoid macular edema now clinically, but sometimes it's still tricky if it is really minimal. Okay, so this is the imaging. Very briefly, we need to get color photos, fundus autofluorescence, and OCT. Okay, then we move to the electrophysiology testing. I have delivered the electrophysiology course to you, of course. We'll not go through this again now, but very briefly, we have 4 tests in the eye-safe standard testing to check the function of different layers of the eye. The EOG, which assesses the function of retinal pigment epithelium. Then we have the full field ERG, with which we assess 2 layers. With the A wave, we measure the function of the photoreceptors, and with the B wave, we measure the function of the bipolar cells. Then we have the PERG, the pattern ERG, again 2 waves, the P50 that gives us an idea about the macular function, and the N95 about it assesses the function of the ganglion cells. And the last one is the visual evoked potential, which assesses the integrity of the visual pathway. So we measure the conduction and the visual pathway and the misrouting in cases of albinism. Okay? We have gone through this in details. We'll just move on now to the 5th assessment modality, which is the genetic testing. I'm happy that Lean is here because this, in fact, their work. This is the work of the molecular biology technicians and scientists. But just very briefly, how do we do the genetic testing? We take a blood sample from the patient. They process it by doing DNA extraction. Please correct if there is anything wrong, Lean. Thank you. And the DNA is fragmented and amplified to, assess the coding exons of the genes to be tested according to the condition. Yeah. Then sequencing is done with different ways. There are many ways available, and the technology, of course, is improving. And the patient gene, the sequence of the patient genes, is compared to the normal sequence to see if there is any variation from normal. And there are panels now for different diseases against which the blood sample is tested. So, for example, if you send the sample to Lean and say this is a case of retinitis pigmentosa, she has a panel for all the known genes with mutations linked to retinitis pigmentosa. 70 genes are around there. Isn't it? Much more, okay, they increased. Okay, yeah. So we don't need to check the whole genome, so that saves time and cost and everything, to just check what are known mutations, and we check against that. And there are databases of the known mutations available, which is continuously updated, of course, because every day we hear about novel mutations in different diseases. So this is the technical side of the lab, in fact, just to have an idea what happens there. Then we move on to treatment. What options do we have for treatment of these dystrophies nowadays? Because as Muhammad and your colleagues, you are excited about we hear nowadays in the press and in the media. As the patients, of course, new treatments are coming. What is really available, what is not available, we need to understand. So what we have, simply, we can categorize in 5 categories. We have first the supportive measures. And so far, this is the most important because it is the only one available now, right now, the supportive measures. Second, we have some pharmacologic options that we can offer to these patients. Third, gene therapy, which is the big promise that is, evolving nowadays. Fourth is cell therapy. Some people call it regenerative therapy. And fifth is the retinal prosthesis or artificial vision. Okay, let's briefly discuss them. The supportive measures. The first thing is the low vision aids. Don't forget this when you see a patient with poor vision, especially in dystrophies. It is sad that, I come across these patients in the clinic with dystrophies. I've been attending for years. Whoever sees the patient, you have retinitis pigmentosa, will see you after 1 year, and nothing is done to help him or her. If you just send them to the low vision aid clinic, at least they can get a magnifier to see things a bit clearer or a bit better. It helps a lot. And this, many, many options are, with the technology and everything, is improving. So they can get some help somehow, based, of course, on the degree of the remaining visual function. There are many technical aids available as well, like, nowadays with the tablets, computers, CCT circuits, and a lot of things. Even for those who lost the vision completely, they can give them machines that reads books and newspapers for them, so you don't feel really isolated, so they have something to help. So no matter how much the visual disability, even NPL, even down to NPL, they can have something to help. Tinted glasses can be useful in some cases, especially when photophobia is a big problem, like cone dystrophies and achromatopsia. We'll touch on this soon. School supports. These, especially children at school, very little things can help as well. So, for example, in children, and I think we have some of the pediatric ophthalmology team here, I don't know if there are any dedicated service in schools here. I'm not aware of it. But it helps. So, for example, children with moderate visual loss, not very severe, just moving the child from the back of the classroom to the front, it just can help the child to continue at school. Because if they sit in the back, they can see nothing, and they can just quit, stop going to school because they don't see. And other stuff also is available in terms of support. National register, as far as I know, there is no one in Saudi Arabia. Is there one, Doctor? No. But in other countries, there is a national register. So people with certain degree of visual disability, we call them partially sighted. So they have some loss of vision, but not very severe. They are registered as partially sighted. And those with very severe visual loss are registered as blind. And blind, of course, doesn't mean they are totally blind, no, but just below a certain limit, okay? So the government takes care of these guys, these patients. They give them support. For example, the employment support, they give them a chance to get employed for a job with which they can cope with their visual ability. And very interesting that, recently, a study was conducted in France, and it's published in the American Journal of Ophthalmology a few months ago. They were studying the rate of employment and of the patient with retinitis pigmentosa in France. And it's very interesting that the employment rate among retinitis pigmentosa patients was higher than the general population. And this is understandable because they are given priority. So companies, for example, they say 5% of the job will go to people with disabilities, different disabilities. Visual disability is one of them. So these guys, they have priority than the general population to get a job. And more interesting that when they compared those, visually impaired people with retinitis pigmentosa to the other employees in these companies and firms, they find significantly higher percentage of these cases with retinitis pigmentosa in senior positions. So they were doing better than the general population, in fact, because the support they receive. Social services is another option. I think also is not very common in Saudi Arabia. So if the patient doesn't have a family or people to take care of them, the health system, they provide social care. People visit them at home. They give them very useful tips to manage in the house. So, for example, how can they go to the kitchen, switching on and off the cooker or the stove? When they put fluid in a cup, for example, how they don't overspill. They give a little thing, but it helps a lot, so they can survive on their own without help from the surrounding. Things that make sound and things like this to help them. And lastly, voluntary work. Many people, again, this is very common in the West, they help the visually impaired people, by doing voluntary work. For example, just one example, I was working in Aberdeen in Scotland. One lady came to us one day in the inherited disorders clinic, and she said, my family, I have family members with retinitis pigmentosa, and I know very well about the disease. I know how to help these people because over the years she has been through everything. I am retiring soon, and I would like to come here every day when you have an inherited disorders clinic to help the patients. She does this for free, you know. So she have like a consultation with them, explain the nature of this, visit them at home sometimes, give them tips and, you know, helpful stuff to survive on their own. And there are many other examples. For example, families with affected members, they invest money, they collect money, and they make charities, develop devices, websites, you know, counseling groups, a lot of things like this. So that's overall the supportive measures, which is the best we have so far. Then pharmacologic therapy, we have some options, as I say, for example, or the most, you know, relevant one is cystoid macular edema in cases of retinitis pigmentosa. This is something we can treat. So we have treatment options like carbonic anhydrase inhibitors, topical or systemic. I usually start with topical. If there is response, that's fine. If not, we can try systemic. Can even be treated with anti-VEGF injections or steroids. The next two modalities are in fact under trials, not approved yet, is the neurotrophic factors and the anti-apoptotic. The neurotrophic factors are important for the well-being and the survival of neural tissue. And as we know, the retina is a neural tissue. There are many neurotrophic factors there. In the normal retina, they are secreted by the molar cells and the RPE cells. So people thought, why not to make benefit of this? Because if we give more of these neurotrophic factors, the survival of these degenerations will be longer, and we give them much longer time with, you know, better visual function. Many of them are under trials nowadays, but just famous example, the ciliary neurotrophic factor phase 2 trial is being conducted at the moment in the National Institute in the States. It's in phase 2 at the moment, then we'll move to phase 3. The other one is the anti-apoptotic agents. You know, the common pathway for all the dystrophies, whatever the pathogenesis is, all at the end feed into apoptosis. And as you know, apoptosis is the programmed cell death. When the damage reaches a certain level, then a decision is made in the cells to destroy the cells because it's no longer useful. So the phagocytic system of the cell itself, it eats up the cell to die. So there are many pathways involved, and there are many agents being tested now to slow the degree of the rate of apoptosis. So again, same idea like the neurotrophic factors, but it's different mechanism to give more survival of these neural cells. Then come to the gene therapy, which is very intriguing nowadays, and I think you are curious to know a little bit of details about this, because we hear every day a new gene therapy happening here, happening there, and we are trying to simplify this to the patients every day in the dystrophy clinics. So why the eye is a very good organ to try gene therapy? The eye is very good compared to the rest of the body. Number one, the accessibility. We can deliver the genes we want to deliver into the eye easier than other parts in the body. Yeah, we can inject it in the eye and specifically at the desired plane. Yeah. Number two, the immune privilege of the eye. These viral vectors in general are immunogenic. If you inject it in the blood, the immune reaction will happen immediately. But in the eye, the immune reaction is less than the rest of the body. And this is an advantage. Number three, the compartmentalization of the eyes. So the eyes, more or less, this is not 100% true, but it's like isolated from the body with the barriers we have, the blood barriers. So we don't have much from the body affecting the eye and much from the eye affecting the body. So again, makes it an ideal location for trying gene therapy. And we have nowadays, with the investigative tools, very useful means to monitor the structure and function after delivering gene therapy. So for example, the structure we can monitor with OCT, and the function we can monitor with electrophysiology, microperimetry, or whatever. And we have two eyes. So in trials, usually we treat one eye and we have the other eye as a control. So you don't need to recruit a group of control cases for the trial. One eye can serve as a test eye and the other one can serve as a control. So all these things makes the eye an ideal location for trying gene therapy. Okay? So what are the aims of gene therapy? Very simply, there are lots of details here. In autosomal recessive and X-linked disorders, what happens is that the genetic mutation results in a faulty protein. The protein which is produced because it becomes faulty, is an abnormal one that doesn't do the function. So there is loss of function. So what we aim in these cases is to deliver a healthy gene instead of the diseased gene. And simply the problem could be sorted out. So if we deliver the healthy gene, the normal protein will be produced and the function will be regained. It's not very simple like that, but it is, that's the principle, okay? But in autosomal dominant, it's a bit more complex because the faulty genes in autosomal dominant, usually they encode for proteins that are harmful to the cells. So they cause problems to the cell. So we need to make these genes silent to stop producing this harmful material and to provide usually we need both. Sometimes you need one, but usually we need both factors addressed. So to silence the faulty gene and to provide a healthy gene that, produces the healthy protein. Just a very brief thing about the CRISPR is not a standard thing now, but it's very, very promising technique for the future, which is, editing. It allows editing of the DNA in vivo. So, for example, if a piece of the DNA of the individual is faulty, with this enzyme, the Cas9, it will allow us to cut the DNA at certain site and program the repair mechanism to repair it in the normal way, not to repeat the defect. So if the DNA is corrected of the patient, then that's all sorted. It's back to normal, and then it functions normally. It's still being under development at the moment. So what techniques are available in gene therapy? Number one, we have vectors. We need to deliver the gene. How we deliver it, we need a transportation mechanism to deliver the gene, the healthy gene, into the affected cells. So these vectors are mainly viral. Viral is the standard way we use nowadays. We have many viruses that could be used. The most famous are the adenovirus, adeno-associated virus, and the lentivirus. Each one has its advantages and disadvantages. But the adeno-associated virus is the most commonly used one because it gives, a good compromise between a reasonable low degree of antigenicity. It's not very antigenic, and it carries a reasonable amount of DNA to correct the disorders. And each one, as I say, is variable about, regarding these factors. The other thing which is very promising is not the standard so far, but is, under development, is something we call non-viral. The problem with the viral vectors mainly are two things. Number one, the antigenicity, because the wall of the virus is antigenic. So it can trigger, it should in fact trigger an immune response in the eye. And in some of the clinical trials conducted in humans, this was seen. There was an intraocular inflammation because of the antigenicity of the virus. So that's one problem. The second is the size of the DNA that the virus can carry, which they call it the payload. So sometimes the gene is big, which the virus cannot carry all this amount of DNA. So this new technology, which is called the nanoparticles, it doesn't need a virus. Just we deliver the DNA itself, wrapped in some biologic materials. So we avoid these problems. You have no antigenicity, and you can put any amount of DNA, and you can repeat it at any time of any dose. So it's still under development, but it's really, really promising for the future. So this is regarding the vectors. And how about the injection site, where we deliver these vectors into the eye? The standard method at the moment is subretinal injection. So the patient undergoes vitrectomy, induction of retinal detachment, and we inject the therapeutic vector under the retina, between the photoreceptors and the retinal pigment epithelium. The good thing about this is that we deliver the vectors exactly where we need, is in the subretinal space. So because most of the problems are affecting the RBE and the photoreceptors. So that is exactly where we want it. But the disadvantages are, number one, needing to do vitrectomy, kind of a big operation. Number two, inducing retinal detachment, which can cause further damage to the photoreceptors that are already damaged. So we don't like that. If there is an alternative, that would be better, isn't it? Keeping in mind that this treatment might need to be repeated. So we don't need, for example, every 2 years or 3 years, we induce retinal detachment again to deliver the medication. So now the thinking is to deliver these, and some trials are going on really, by intravitreal injection. We don't need to do vitrectomy or induce retinal detachment. This has many advantages, of course. It's easy. Anyone can do it. Very simple. Can be repeated as much as you want. Yes? But the problem is that when you deliver these viral vectors in the vitreous, they don't penetrate a lot. Some of them reach the subretinal space, but not a lot. And we think, our understanding now is that the limiting thing is the internal limiting membrane, because it is like a barrier for the invasion by these viral vectors. So how to sort this out? One way which people are working on at the moment, is to do enzymatic digestion of the internal limiting membrane. Like the same idea of ochraplasmin, we inject this enzyme in the eye. Sometime before the injection of the vector, it should digest, or trying to see if it digests the internal limiting membrane, remove this barrier, and then inject the vectors in the vitreous. That's one way. The second way is to use the nanoparticles without viral vectors at all. So these are the basic techniques at the moment. The fourth modality, which is very, very exciting, in fact, is the cell therapy. So the aim of gene therapy is to rescue the viable cells. So the cells that are still alive, we try to rescue them with delivering the healthy gene. So we revert them back to the normal status so they survive, they don't die. But the cell therapy is, on the other hand, it targets the dead cells. How about the cells that are dead already? See, in the clinics, if you come to the dystrophy clinic, most cases are really, really advanced. Very little remaining, if any. So how to sort this out? So we need to replace these cells by other new cells, if possible. And this is the main theme of the cell therapy. So what is done? So as I say, it's used to replace the already lost RBE cells or photoreceptors, and others, of course. Types, we have several types. The first is the embryonic stem cells. There are many details here which are really, really exciting, but we don't have time to go through all of them. But very briefly, the embryonic stem cells, in the human embryo, they can divide, and they can differentiate into any type of cell, because that's how we were created. One cell divides and then differentiates into, all types of cells in our body, including all cells in the body. Yes, so this can be used, and it can be programmed to develop into a specific type of cells that we use to replace in the diseased individuals. Number two is something I'm sure you heard about. It's called the induced pluripotent stem cells, iPSC. With embryonic stem cells, we take these cells from a human embryo. The people who get, in vitro fertilization, they prepare several zygotes and implant some of them into the uterus of the mother. And the rest, they don't use them. So they ask, the family, would you like to donate these little embryos for research? Some people accept and some people don't accept. And there are ethical issues about this, because this is like a little human being. You use him or her, this embryo, without their consent, and there are many ethical issues. So there are ethical issues about the embryonic stem cells, in addition to the antigenicity. These are foreign cells that will trigger immune response, of course, yes? So the idea of the pluripotent stem cells induced was really clever. This was done in Japan, I think it's 2006, by Yamanaka and his group. Was a big breakthrough. The man discovered that if we take somatic cells from the human body or an animal, we can revert it back to the original state of the stem cells. We can convert it to a stem cell again, like making an adult person become a child again, go back to his original history. And it retains the same properties. It can divide, and it can be programmed to develop into the cell type we want. Okay? Lots of exciting details. I'll leave it to the end if you like to have more about this, iPS. And to avoid the problem of the, transferring these cells from another individual or from animal, we can even take it from the same individual. So we can take, for example, the most common cells used in this technique are the skin fibroblasts. We take the skin fibroblast, give them certain factors injected in the cells, and 4 genes specifically, they become, a stem cell. And they divide, then they become programmed to the cell layer we like, for example, retinal pigment epithelium, and then we use this layer to be implanted instead of the lost retinal pigment epithelium. Okay? So endogenous will be even better to avoid, the antigenicity, at least theoretically. So the animal studies with these, techniques, they showed complete anatomical and functional layers of retinal pigment epithelium and photoreceptors layers. It was complete differentiation, absolutely comparable to the normal layers, which is amazing. And then in the human studies, in this part, this technology specifically, the trials in AMD are a bit ahead of the inherited disorders. In the academy this month, the people were presenting the results of phase 2 trials in atrophic AMD in humans with very, very promising result. So the sheets of the, synthetic RBE implanted successfully and is surviving then for at least 2 years and is functional, which is very good. So not in all cases, of course, but this is a promising modality for people who had no treatment before. You had no cure for this type of problem. Same trials are being repeated now. Phase 1 and 2 are recruiting people in humans with inherited disorders. But this is not without risk, of course. So for example, in the exogenous, as I mentioned, there are ethical issues about using, human embryos. The immunogenicity, it can trigger immune response and tumor formation. These cells can divide out of control and cause a tumor in the eye. The endogenous, it overcomes most of these problems, but if you take a cell from the same individual with a genetic mutation, this cell will carry the same mutation. So we need to correct the genetic mutation of the endogenous cell first by genetic engineering, then convert it to a stem cell, induced pluripotent stem cells, then programmed to develop into the layer we like. Okay? So it needs 2 stages, in fact. 1 stage to correct the genetic defect, and then we move on to the usual pathway. Okay? So this is briefly what happens in the cell therapy. The last one is the retinal prosthesis or artificial vision. We have 2 commercially available devices at the moment. Number 1, which is called the Argus 2 implant. Some of this has been done already in KKESH. And the other is called the Alpha IMS. The difference is that the Argus is implanted on the surface of the retina, and the Alpha IMS is implanted under the retina in place of the photoreceptors. So this is applied to people with really, really poor vision, like perception of light only. And it gives a modest improvement in visual function. We don't expect these guys to gain normal vision, but at least they see, big things in front of them, so they don't bump, into a wall or something. They can find the door to go through it. But the technology is improving a lot, so many, many devices are being developed at the moment. And with improvement in the technology, the pixels in these devices will increase and hopefully allow better resolution of the image seen by the patient. So just to show the 2 examples very briefly, this is the Argus 2 implant. It has an extraocular part, which is this, and a part associated with the eye here. So in the extraocular part, the patient wears glasses with a video camera here. This video camera captures the image and sends the image to this video processing unit that converts the image into light intensities. So in different pixels of the image, it converts the, what you see into light intensities. And then it goes back to a transmitter here that transmits this information to an explant, a device here, on the surface of the eye, like scleral buckle. We put it on the surface of the eye like a scleral buckle, fix it with an encircling band. So it sends wireless to this. This is without a wire. And this is attached by a wire that goes through the pars plana to the microarray here. The microarray is, in Argus 2, it has 60 pixels on the macula, on the surface of the macula. So this microarray, it has the information based on the image seen by the camera. It gives electrical impulses. These electrical impulses are delivered to the ganglion cells. So now bypassing the photoreceptors and the bipolar cells directly on the surface of the retina to the ganglion cells. The ganglion cells send the image through the optic nerve to the brain. So, and the patient, as I say, gets, it's not very high resolution, but at least they can see things around them. That's the Argus 2. In the Alpha IMS, it's a bit different. It's inserted under the retina, so exactly to replace the photoreceptors. So it's stimulated by the natural light that, as we see normally, the light gets focused on the retina, stimulating the photoreceptors. Here it stimulates these electronic receptors to generate electrical impulses. The electrical impulses are transmitted to the bipolar cells, the ganglion cells, and then the visual pathway. And the electronic chip here is connected by a wire that goes under the skin to a controller here in the temple, at the temple. And the patient has, a controller to switch the device on and off and to increase or decrease the degree of illumination. The Alpha IMS is supposed to give higher resolution because it has 1500 pixels compared to the 60 pixels in Argus 2. So these are the ones, as I say, they're commercially available and approved at the moment in the market. So this was the general introduction about the dystrophies, how we approach the case. We take history, we do a clinical examination, we do the imaging, we do the electrophysiology testing, and now we know about the treatment modalities available and on the horizon. Now we'll just touch on quickly on the photoreceptors dystrophy, because we cannot cover everything, as I say. Just a few examples of them to put this into application. So there are many photoreceptors dystrophies. Again, we cannot cover them all. We'll just take the famous ones. So we have, for example, Leber congenital amaurosis, LCA. We have the rod cone dystrophy that we used to call retinitis pigmentosa. We have the cone rod, which is the other way around. It affects mainly the cones and in addition to some rods. We have the cone dystrophy and the achromatopsia. There are others, of course, but let us focus on these at the moment. First one, LCA. This is an 11-month girl presented by her parents to us because of no vision. They notice that she has no vision, and she has abnormal eye movement, continuously rubbing her eyes. What do you think? Okay. So the parents are cousins, but they don't have visual problems. Leber, as you know, is autosomal recessive, so everything is matching. Is the first child, so there is no other family members. On examination, the girl showed horizontal nystagmus. She cannot fix to light. She had positive oculodigital sign and in ophthalmos, and refraction was done by the PEDS team, was about 6.5 plus in both eyes, around spherical equivalent. Anterior segments were normal. Her fundus, this is not her picture, but is a picture from a similar case because we don't get a fundus photo in this case. If you look at the fundus, you see just areas of hypopigmentation. And in Leber, in LCA, the fundus picture could be really, really variable. Abdullah was with me on Sunday. We saw, I guess, Leber was absolutely normal fundus. It looks absolutely normal. So it can be normal. It can show areas of hypopigmentation, pigmentary degeneration, areas of atrophy, even coloboma. So it can be quite variable. We couldn't do much more imaging here because of the age, of course. But we did the electrophysiology. And if you look here, this is the electrophysiology done in KKESH. And as we discussed previously, this is not the ISEV, but let us focus on the white stimulus here. In the rod response, it's absolutely flat. In the cones, it's not clear. Is it clear on the sides? So yeah, please look at the sides. I know it's not very clear. Everything is flat, basically. The rods and the cones, both of them are flat. No response at all. So this is matching with LCA. Genetic testing, we sent the blood sample was sent a while ago and tested against the LCA panel. It has about 27 genes and nothing was found. But because of we were pretty confident that this is, it looks like Leber, they did, extended testing and found, one of a bit unusual mutation, IFT 140 missense mutation. So what is this? We will not discuss all the mutations today, of course, because of the time limitation. The intraflagellar transporter is important for transport of proteins in the cilia. And of course, the photoreceptors are modified cilia, isn't it? And in fact, it has a cilium connecting the inner and the outer segments. So what happens here is our understanding is that the opsins in the inner segment cannot be transferred through the cilium to the outer segment. So there is no phototransduction. So it causes, ciliopathies that can affect other organs in the body, like, the kidney and the brain and the ears and others. And in fact, the girl was found to have Menzer-Saldino syndrome, and it was very good to know because she had, serious CNS problems and was referred for, management by the relevant teams. Okay, how about gene therapy in Leber congenital amaurosis? This is the most, updated thing we have, or the most advanced thing we have nowadays in terms of gene therapy. So just we'll touch on this quickly. This is one specific mutation, which is the RPE65. As I say, this is has the most advanced, progress with research in terms of therapy at the moment. Phase 1, 2, and 3 trials have been conducted in humans, done already using adeno-associated virus. The first, based on the results of phase 3 trials, the first product, which is called Luxturna, the results of phase 3 were published already in July this year, and the company is called Spark Therapeutics. They have, of course, the intellectual properties of the drug. They used this dose to inject subretinally in both eyes, after the phase 1 and 2 that it was done in one eye, and was using the other eye as a control. And in the phase 3 trials, they treated 20 patients and compared them to 9 controls. The primary endpoint of this trial was something we called multi-luminance motility test. We don't aim in these cases to gain normal vision. No, it's just to allow them to navigate independently in different illumination conditions. So in bright light, in slightly less light, and so on, and see with which illumination condition they can navigate. And the study cases, even with the smallest degree of illumination, they managed to navigate without help compared to control, which was success. No serious side effects were reported with this dose, and the company was clever and lucky because with other doses in other trials, antigenic reactions were observed, but here were not observed. So perhaps this dose is quite reasonable. It gives a good effect without causing much of reaction in the eye. And the drug is submitted now, is already submitted for FDA approval, and we expect it to get approval, hopefully in 2018, but might take longer. And this is the most advanced thing. So if the patient asks you, nothing approved till today, nothing, zero in terms of gene therapy, but this will be hopefully the first one to be approved, we hope, in 2018. Other genetic mutations, there's a lot of them. Of course, they are a bit behind. Trials are going on in phase 1 and 2 at the moment, and hopefully will provide more options in the future. Okay, let's move to another example. The rod cone dystrophy, which we used in the past to call retinitis pigmentosa. Because as you know, in the past we thought that retinitis pigmentosa is a disease of rods, but this was found to be wrong. It affects both, but mainly rods, so rods more than cones. So this is a 19-year male presented to us with a history of poor night vision since early childhood. He couldn't determine exactly when. Then the vision started to become affected recently. The parents are cousins, as the usual case here. They have no visual problems, and they have 3 healthy sisters. No medical problems. Visual acuity was around 20/40 in both eyes, and the anterior segments were normal. So these are the foci of the patients, the right and the left eyes. I know that the Optus photos are not, the best to see the findings, but you see, again, maybe on the side monitors is a bit clearer. You see the intraretinal pigment migration in the mid-periphery that people, used to say, these are bone spicules. That's the proper name, intraretinal pigment migration. There is some degree of optic atrophy, and the vessels are a bit attenuated. I know it's not very clear with the white field image. The autofluorescence was done, and in fact, this gives perhaps a more clearer view. If you look at this ring, which is quite typical of cases of retinitis pigmentosa, you see a ring at some location, maybe around the arcades, maybe bigger, maybe smaller, and the bigger the ring, the better the news. Because this ring demarcates the peripheral areas which are already lost. So what is peripheral to this ring is gone. And the ring is like the limit of what is remaining centrally. So when the ring is bigger, that's good news. When the ring is smaller, that's bad news. And inside, the signal is a bit high because degeneration is going on. The photoreceptors are degenerated, engulfed by the RBE, more lipofuscin produced, and then with time, it's toxic to the RBE, then causes the RBE to atrophy. And in the center, the center of the fovea in autofluorescence, it should show a reduced signal, but here it has high signal. High signal means degeneration is going on. So it has also a cone component. It's not only rods. So the rods, as we saw, lost peripherally and extending to the center, and the cones also, they have a problem, and there is like a bullseye appearance because there is an area of loss around the very center. So the OCT was done. This is the right eye, and this is the left eye. If you look at the OCT, the RBE is thin, and the photoreceptor layers, if you look at the ellipsoid zone in the right eye, here you can see it. This is like disintegrated, but still there a little bit in the middle. But outside this area, no, it's not continuous. So it's lost in the peripheral part, and only a small part in the center is still there. Pretty similar in the left eye. And what else do you see on the OCT? Cystoid macular edema. So don't forget this in cases of retinitis pigmentosa. Then the full field ERG was done. Again, look at the side, maybe a bit clearer. The rod response, there is no waveform at all in the rods, but in the cones, there is very, very little. The flicker has a little waveform there, and the 1.5 hertz, there is very slight, very small A wave and B wave. So the rods are gone totally, and the cones, they are affected, but there is still there some function. So how would you call this? Is it rod cone or cone rod? Rod cone, that's it, yeah. This blood sample was tested, was sent for analysis. We didn't receive the result yet, and I don't know if the number is bigger now, over 3,000 mutations are identified so far. Sorry? Okay, yeah, right. So we don't have the exact mutation in this patient yet, but the inheritance pattern in retinitis pigmentosa, as you know, it could be autosomal dominant. If you want just to remember one of the genes responsible for the dominant cases, the rhodopsin gene. Or autosomal recessive, which is the most common here, as I said, in Saudi Arabia. If you want to remember one, is the RB65 that we mentioned in Leber congenital amaurosis. The X-linked, it is the, two genes are identified, the RBGR and the RB1. But sadly, in up to 40% of cases, we cannot identify the gene. Correct? Good. So not always we can reach the specific gene in these cases. What therapeutic options are available? Number one, the supportive measures, most important, because that's all what we have at the moment. Pharmacologic agents, don't forget the cystoid macular edema. We need to treat it to preserve the central vision as much as possible. As I said, the ciliary neurotrophic factor is still under trial in phase 2 at the moment. And just a little touch on vitamin A supplements. It has no proven roles because number one, in retinitis pigmentosa, there is no deficiency of vitamin A. It's not a problem with vitamin A deficiency. But some people think if you use it as an antioxidant, it's a totally different mechanism, it could help. We have very contradicting results from trials. None of these trials were, properly conducted. Good quality trial, in fact. But some of them say it's helpful, some says it has no effect, and some says it has a harmful effect. So nothing conclusive, really, regarding vitamin A supplementation. And don't forget cataract surgery. If they have significant cataract, the cataract can be removed to improve the central vision. That's all what they have, the central vision. Abdullah, you listed a case on Sunday, isn't it, with retinitis pigmentosa and significant cataract. That's anything that helps, we can do. Gene therapy, as I mentioned, the RPE65 is the one that's almost, just reaching, approval hopefully next year. But the others are still being tested. Cell therapy, as I say, the animal models showed very promising results to generate sheets of RBE layers and photoreceptors. But, human studies are just starting, to apply this at the moment. And the prosthesis, as we discussed, we have the Argus 2 and the Alpha IMS for people with really, really poor vision, like perception of light. Okay. See, maybe we take quickly the cone rod. This is 33 male, presented with reduced vision in both eyes for the last 10 years. Parents are cousins also, no family members affected. 2,300 in the right eye and counting fingers in the left eye, normal anterior segments. And the fundi, as you see, peripherally, again, look at the side, it might be a bit clearer. A little bit of peripheral degeneration, but mainly at the macula. And if you enlarge the macular, I think we have 5 minutes, we'll just quickly fly through this. If you look at the macula, you will see pigmentary changes and atrophic changes, maybe not very clear with Optus, maybe slightly clearer in the left eye. And with autofluorescence, as you see, it's just the other way around of the rod cone. You see the ring is happening here, but something is starting from the center and going outwards. So the central part is lost totally, and around it, the signal is low, meaning these cells are dying, and this is the high metabolic load. So the thing is starting from the center and enlarging peripherally. So it's just the other way around. This is cone rod instead of the other one, the rod cone. We'll just fly quickly. The RBE, the photoreceptors layers are nearly totally gone in these cases. And if you look at the full field ARG, in the rod response, you can see some waves there of low amplitude, but there is some rod response. And if you load at the cone on the right-hand side, the flicker is totally gone, and the 1.5 hertz is really, really diminished. So the rods are not too bad, but the cones are markedly affected. So this is cone rods. Same thing, the supportive measures. You need magnifier, you need tinted glasses. The gene therapy is under trials, as I say, and cell therapy is under trials. So I'll just jump quickly to the achromatopsia, the last one, to conclude. So in achromatopsia, we have something called achromatopsia and something called blue cone monochromatism. They are two different conditions. The achromatopsia is autosomal recessive, and the gene is on chromosome 7. The other one is X-linked on the X chromosome. In achromatopsia, all colors are affected. That could be complete or incomplete, but in blue cone, it is only the red-green because of a defect in the genes encoding for the red and the green opsins in the cone cells. So let's take one example of a complete achromatopsia, because we're conducting a project at the moment, and this is one of the cases in the study. This is a 7-year-old boy presented with nystagmus, severe photophobia, and this is very important, at birth. Reduced vision in both eyes. The parents are not relatives in this case, with no visual problems, and he has no other affected siblings. No medical problems, no problems with night vision. Vision was around 2200 in both eyes, normal anterior segments, and the fundi look like this. To me, this is a normal fundus. The sheen you see around the disc and the arcades is just the internal limiting membrane, because the patient is young, he's 7, and this is quite normal. And if you look at the autofluorescence, it looks very normal for a 7-year-old. These two white dots are same place in both eyes. I think this is artifact from the lens of the Optus camera. So pretty normal distribution. The OCT is unremarkable. In fact, maybe very, very, very little interruption of the ellipsoid zone in the very middle. It's not very clear because there's just 7 years, maybe not very cooperative with the imaging. So in summary, the structure looks pretty normal, the structure. But with the full field ERG, as you see, the rod function, it looks pretty good, and the cone function is affected. The flicker is gone, and the other waves are depressed. So it is like cone dystrophy, but the difference is that the anatomy here looks intact. So genetic testing was done, and we found a positive nonsense mutation in the cyclonucleotide-gated alpha subunit 3 gene, and this is one of the 5 genes responsible for cases of achromatopsia. The parents are sampled to confirm, the diagnosis, and this gene, in fact, encodes for the alpha subunit of the cyclic GMP-gated channels in the cone cells. So mutations in this cause impaired phototransduction. So when the cones get stimulated, these channels are supposed to open for the electrolytes to move and generate the electrical impulse that is propagated through the visual pathway to see the colors. Because of the defect in the alpha subunit here, the channel doesn't open, so the electrical impulse is not generated, and that's why the patients, you don't see colors. So as I say, 5 genes have been identified, and the very interesting thing in gene therapy in cases of achromatopsia is that in animal studies, they showed that their normal function comes back completely even after a long time. If they have been left like this for years and then treated, they get the same result as if you treat an animal who's just, very young in age. And this is contradictory to all the other dystrophies, because in dystrophies, usually as time goes, you lose more and more cells, and you cannot rescue the dead cells. So again, this tells us that the problem is not anatomical in these cases, and that's very promising. It has very big implication for humans, because even in later stages, we can treat them. And based on that, phase 1 and 2 trials are going on in humans. Very briefly, these supportive measures, tinted glasses are important in these cases. Many technical aids are available. Some of them are fancy. For example, the iPorg, it converts it's glasses that the patient wears with a camera. It sees the colors and converts the color to a sound that is converted to the mastoid process, and the patient learns that this sound equals red, and this sound equals green, and this sound equals this. So they know, the colors they see. The second is the color. It is a torch light. you shine it on the object in front, and it tells you is it red or blue or whatever. And because the patient, they see colors as shades of gray, they learn that this shade of gray equals red, and this shade equals yellow, and so on. So I hope today we just gave a good introduction for the retinal dystrophies. It's not an unfamiliar topic to you anymore, and we gave some examples of the photoreceptors dystrophy, and thank you very much.
Thank you, Dr. Ehab. I just have one general comment for the RPE65 gene therapy trial. The RPE65 was always a very successful example for the LCA and retinitis pigmentosa. However, unfortunately, in the Saudi population, RPE65 only represents 1% of the cases of genetically being tested for this mutation. So, I mean, it will benefit these patients for sure, but it will not benefit so many patients of these conditions. Just I thought this is a general information for you guys to know.
Hello? Yes. Hello, good afternoon, everybody. Let's start the Grand Round topic today. Our speaker is Dr. Asaba Rashid, Senior Consultant here at KKESH, all of you know her, and she's going to enlighten us about challenges in vitreomacular interface syndrome. Is everything ready?
Finish?
Yeah, sorry. So, Saba, yeah, please.
Good afternoon, ladies and gentlemen. Assalamu alaikum. Today I choose this topic, which is challenges in macular traction syndrome. I remember on 2003, which is 14 years ago, my first grand round was macular hole. So let me share with you, macular hole now it is related to the same syndrome. So let me share with you the changes that happened during this 14 years. In terms of definition, pathophysiology of vitreomacular traction syndrome and macular hole, classification, and management. So let's start with the definition. Definition, vitreomacular traction syndrome represents abnormal traction of the vitreous gel causing distortion of the foveal with functional changes. And the visual symptoms including decreased vision, metamorphopsia, and photopsia. In order to understand the pathophysiology of vitreomacular traction syndrome and macular hole, I like to mention something about vitreous anatomy, vitreoretinal interface, posterior vitreous detachment, so that we can understand the pathophysiology of this syndrome. So let's start with this slide, which is the vitreous anatomy. Just to simplify it, the vitreous has two main regions, cortex and gel. The cortex bound the gel. Both of them have hyaluronic acid, and both of them have collagen fibers type 2. However, the concentration of collagen fibers in the cortex more than in the vitreous, and the gel has hyaluronic acid more than in cortex. The interface, which is the cortical vitreous, bound to the internal limiting membrane of the retina, and this is what we call vitreoretinal interface. The vitreoretinal interface has strong attachment in the vitreous base, at the back of the lens, fovea and parafoveal area, margin of the optic head, and along major blood vessels. And these forces maintained through adhesion molecules that we call it laminin, fibronectin, and heparin sulfate proteoglycans. In the process of the posterior vitreous detachment, which is mainly aging process, but can happen secondary to any pathology that cause anomalous vitreous. What happened that you have decrease in the collagen fibers, you have decrease in the hyaluronic acid, and both of them cause shrinking of the vitreous body, and what we call it is liquefaction. And the process of liquefaction, you have pockets of a fluid that border by collagen fibers. With the pressure, these pockets rupture, and through the opening, the liquefied vitreous escape from the posterior back of the pocket and get separated the posterior hyaloid from the inner surface of the retina, namely the ILM, which is internal limiting membrane. The incidence of posterior vitreous detachment increases with older age, because with older age you have degenerative things, degenerative process at the collagen fibers, and also decreasing in the hyaluronic acid. Normally, this process starts around the macula, then get up to the vitreous base, and sometimes take months, and sometimes take up to years. For unknown reason, during the process of posterior vitreous detachment, group of patients have persistent vitreous around the macula, and they have a normal pathology at the macula. The continuous vitreoretinal traction causes macular pathology such as vitreomacular traction, epiretinal membrane, cystoid macular changes. And as I mentioned before, this process can be happen to secondary, not related to the age only, but can happen secondary to myopia, trauma, laser injury, intraocular surgery, retinal dystrophy, inflammation, and tumor. So now we understand the anatomy, we understand the pathophysiology, and we understand the process of posterior vitreous detachment, which is related to the vitreomacular traction syndrome. What about the classification? In the past, and we are speaking about more than 20 years ago, vitreomacular syndrome, idiopathic epiretinal membrane, macular hole, have often been considered as a distinct entity. We said macular hole separate, we said epiretinal membrane separate, and we said vitreomacular traction separate. However, with the emergence of the OCT in the last 2 decades, make the physician understand more about the pathophysiology, about the diagnosis, and about the follow-up. And nowadays, vitreomacular traction defined as one syndrome that can hold under it variety of vitreomacular interface abnormality like macular hole, epiretinal membrane, cystoid macular changing. So now it is one syndrome that includes all these entities. If we go back also 30 years ago, and when you said idiopathic macular hole, and the physiology or pathophysiology of macular hole, they postulated that because this is involution macular thickening, which is precursor for the macular hole development because this is of age process. They propose that choroidal ischemia secondary to cardiovascular disease cause thinning of the cornea, inadequate supply of the fovea, causing fovea thinning and ultimate macular hole development. Hormonal influences also was studied, and as mentioned, the macular hole was commonly seen among the female, and probably it is related to the menopause female or the patient who had hysterectomy or estrogen therapy. However, the theory of vitrofoveal traction mechanism, anterior-posterior transvitreal traction by vitreous extending to the vitreous base, and also tangential vitromacular traction caused by migration of proliferation of molar cells, which is related to the aging process. This is the common theory that worked since that time. And especially about the tangential vitromacular traction, which is proposed by Gaz classifications on 1988, if you remember this slide. And they staged the idiopathic macular hole because he described that the macular hole is open through the centropetal technique. And this is caused by tangential traction caused by glial cells from the molar cells, glial cell proliferation. So he classified it to stage 1, which is impending macular hole, and this corresponds to central yellow spot, or stage 1A or stage 1B, and this is corresponding to either yellow spot or yellow ring. And the hypothesis beyond that this is a yellow appearance because what you get is like a dehiscence of the photoreceptors from the retinal pigment epithelium. The molar cells become more visible, and this is content of xanthophyll, and give you this picture of yellow. It can be like a spot or ring. Stage 2, smaller hole, is associated with vitromacular traction. Stage 3, large hole without posterior vitreous detachment. And stage 4, full thickness macular hole with PVD. And this is a classification proposed by Gaz in 1988, and his theory depends mainly on the tangential traction caused by the glial cells proliferation. Previous study also study about the risk factor, general risk factor like cardiovascular disease, hypertension, diabetes, CVA, hormonal influences also, as I mentioned, it's a predisposing factor for the macular hole, old age, and also elevated plasma fibrinogen level. The risk factor of the follow-up that developed macular hole also was a study. For example, eyes with no PVD in either eye were at higher risk. Eye with PVD in the full thickness macular hole, eye, but no PVD in the other, we call it intermediate risk. However, if the eyes have PVD, both eyes are of no risk. However, we are seeing, and also a study mentioned about macular hole can develop even without with complete PVD. And this is the examples of the yellow ring, which is impending macular hole that proposed by Gaz, and the lower slide, full thickness macular hole. Now, with the new classification, is depend on the OCT mainly. So, different study classified the vitromacular traction according to the configuration on the OCT by J-shaped or V-shaped, and this is the configuration of the vitromacular traction in relation to the macula. Some study classified into focal and broad, and this is depend on the measurement of the diabetes of the diameter of vitromacular traction. And more recently, Duker et al. And his group published the International Vitromacular Traction Study Group. And basically, they study the vitromacular traction syndrome as one entity into the following. Vitromacular adhesion, in which you have vitromacular adhesion without distortion of the fovea. And usually this patient is asymptomatic. And also it classified to focal and broad according to the measurement of the diameter. It classified into isolated, primary, which is aging, or concomitant, it is secondary to other cause. Number 2, vitromacular traction, by definition, there is a vitromacular adhesion that causes distortion of the fovea structure and vitreoretinal interface. And usually these patients are symptomatic. The classification also by size, focal or broad, or also presence of concurrent retinal condition, isolated or primary or secondary. Full thickness macular hole, by definition, which is interruption of all macular layers starting from internal limiting membrane to the retinal pigment epithelium, and classified also according to the size, small, medium, large, and also classified according to the presence of vitromacular traction, and also by cause, whether it is a primary or secondary. Lamellar hole, which is by definition, it is irregular foveal contour. And lamellar hole is only defect in the inner retinal layer. Not necessarily that you have loss of inner retinal layer, rather than defect in the inner retinal layer. And usually it's associated with schisis. And usually they have good visual acuity because the photoreceptors are intact. The last the definition for macular pseudohole. And macular pseudoholes are seeming like a heaping of the fovea. And this is usually you have epiretinal membrane. And this is the appearance caused a macular pseudohole. There is no loss of retinal tissue. So now this is the classification that now we are depending on. This table shows the classification in the comparison with the older classification proposed by Gaz for idiopathic macular hole. So stage 0 corresponding to vitreomacular adhesion, so the fovea is normal. Stage 1, impending macular hole, which is corresponding to vitreomacular traction. Stage 2, small hole, which is corresponding to small or medium full thickness macular hole with vitreomacular traction. Stage 3, large hole, which is corresponding to medium or large full thickness hole with VMT. And stage 4, full thickness macular hole with PVD, which is corresponding to small, medium, large, full thickness macular hole without VMT. So it is almost the same things, but they gather it in one syndrome. And from the same study, there was a comments about each stage of the disease. For example, for vitreomacular adhesion, the comments of the reviewer that has been called stage 0 in the past, as I mentioned, when contralateral eye has full thickness macular hole, normal appearance on clinical examination, no symptoms. For vitreomacular traction, may or may not have yellow change in the central macula. And this is really seeing in our experience in the clinic. Sometimes you see vitreomacular traction by the OCT, but without seeing the fovea, the yellow spot. And they refer it, as I mentioned, by impending macular hole, if the full thickness macular hole present in the other eye. For small full thickness macular hole, their common visual acuity relatively good. And usually they are responding to the pharmacological treatment and also for vitrectomy surgery. For medium full thickness macular hole, high possibility of success with vitrectomy surgery. And for large full thickness macular hole, slightly less probability of successful closure with vitrectomy surgery. Yeah, thank you. So, for example, this is vitreomacular adhesion, and you can see the foveal contour is preserved, and usually the patient is asymptomatic. This is foveal traction caused by vitreomacular traction. This is the lamellar hole. When I said there is a defect in the inner retinal layer, usually they maintain a good vision if the outer nuclear layer and the ellipsoid zone is intact. This is full thickness macular hole with the separation of the posterior vitreous with the PVD, and this is epiretinal membrane. This is a typical picture. It's, I don't know whether my colleagues agree with me. When the patient presents with the diabetic macular hole, diabetic macular edema, huge one, sometimes it ends with the lamellar hole after repeated injection after repeated intravitreal injection. For example, this patient, he was treated with intravitreal injection. He has a huge macular edema. The macular edema subside, and he ends with this lamellar hole and schisis. Now, it's an important question. Who will develop macular pathology depend on which category of the OCT that you are finding. Studies showed that the maculopathy type related to the structural integrity of the macular size and strength of VMT. For example, if you have focal VMT, there is a tendency to develop cystoid macular edema commonly, which is according to the study 88.9%. Impending and full thickness hole in 61.1%, subfoveal detachment in 16.6%. However, in the broad vitreomacular traction, more tendency to develop diffuse retinal thickening. And so they develop epiretinal membrane, although in the same study they mentioned one case developed macular hole. So probably the configuration of the OCT and how much the traction exerts on the macula can predict which type of macular pathology you will get later on. What about the management? There is 3 options for the management: observation, pharmacological intervention, surgery. Let's start with observation. It is controversial, especially with the thought that vitreomacular adhesion, especially if it is primary the vitreomacular adhesion, it's considered as a stage of normal vitreal gel aging. So it is aging process. And probably they will have spontaneous release of the traction. So why I will treat this patient? And one study showed that spontaneous resolution of VMT in 53% of eyes that had tractional cystoid macular edema. Recently, one study, which is John et al., investigated 106 eyes of vitreomacular adhesion by OCT and was graded according to the severity of the traction as the following. Grade 1, incomplete cortical vitreous separation with attachment at the fovea. Grade 2 is grade 1 in addition to presence of intraretinal cyst or cliffs. Grade 3, grade 2 in addition to the presence of subretinal fluid. And he found that 32% of the eye, there was a spontaneous release of vitreomacular adhesion. He found that 57% was in grade 3, those with subretinal fluid. However, the remaining 2 groups, 30%, their posterior hyaloid separated. 16% of eyes show progression in which pars plana vitrectomy done. So the author recommended observation can be for variable options for managing mild symptomatic vitreomacular traction based on OCT. And also we are seeing this in our clinics. For example, this patient, he has a diabetic macular edema, and you can see he has a vitreomacular adhesion. He has a vitreomacular adhesion. With the frequent follow-up, the posterior hyaloid gets separated and the edema gets subsided. This patient underwent focal laser. Another patient, he presents with the cystoid macular edema, and you can see the vitreoretinal adhesion. This patient underwent macular laser with intravitreal injection, and you can see how nice the posterior hyaloid gets separated. He is now under the intravitreal injection still. This is another interesting patient. He's 75 years old, pseudophakic. And I was following him because of macular edema in his right eye. Maybe this is on 2013. He presented last year with the vision dropped to 20/50, and he has some metamorphopsia symptoms. And as you can see, he has vitreotractional and some foveal disturbance. I offered him surgery, and he refused and preferred to wait. The vitreotractional is increased. This is maybe 3 months later, and the vision dropped to 20/300. And as you can see, he developed also macular hole. And this is different cuts from the same eye, the same time. You can see the avulsion of the retinal tissue with some posterior hyaloid, and you can see this the block of the avulsion. As I mentioned, in one cut he has a small hole. Also, I offered for him surgery, but he preferred to wait. This is maybe 6 weeks after. I get the impression that his hole is closing, but posterior hyaloid is completely separated, and you can see this avulsed tissue very clearly. So also he preferred the patient to wait. This is the frequent follow-up. As you can see, his hole is getting closed, and his vision get back to 20/50. It is unusual case, but it can happen. The spontaneous resolution of full thickness of posterior hyaloid and the closure of macular hole. What about the surgical intervention? This is standard of care for symptomatic vitreomacular adhesion. Why? Because the advances and improvement in surgical techniques, use of vital dyes to stain peritoneal tissue during vitreoretinal surgery, what we call chromavitrectomy, and also advent of OCT technology. The principles of macular hole surgery, which is always based on the study and based on our experience, have high anatomical and visual success. So the basic is pars plana vitrectomy, peeling of posterior hyaloid, ILM peeling, intraocular tamponade, and post-operative face-down position, which is nowadays controversial. So the pars plana vitrectomy and peeling of posterior hyaloid is very mandatory because you are taking the abnormal vitreous and you are taking all the forces and the traction caused by the abnormal vitreous. So it is a mandate, pars plana vitrectomy with peeling of posterior hyaloid. What about the ILM peeling? ILM peeling is very important also for macular hole surgery because it removes the residual adherent vitreous cortex eminent on the ILM surface, also removing the associated fibrocellular collection, and also remove the rigid ILM, causing a retinal glial cell profilation, and will enhance the closure of the macular hole. What about the use of the dye? This is also very important. We are using commonly the triamcinolone to stain the posterior hyaloid during the induction of the posterior hyaloid. ICG, a beautiful dye, has affinity to stain the tissue, but the problem of the toxicity nowadays we are not using. Tribani blue, also it is good, especially for the epithelial membrane staining, and it poses safety profile. Brilliant blue, which is the common dye that we are using, and it is very good, have affinity for the internal limiting membrane to stain, and has also safety profile. What about the using of the intraocular tamponade? You have three options: gas, silicone oil, air, and this is individualized and based on which type of the case that you are. If it is big, if it is a chronic, so this depends on the surgical choice. And the importance of the tamponade is keep the fovea dry and also providing a scaffold for the cell migration. So also it is mandatory. What is the prognostic factor for postoperative vision? Better visual outcome associated with shorter duration of symptoms, lower preoperative macular thickening, and focal VMT, which is configuration of the V shape. However, the worst visual outcome associated with partial PVD, temporal to the fovea, which is what we call J-shape configuration, if you have also prominent cystoid macular edema, because this tend to induce macular hole or macular atrophy postoperatively, and also we are seeing this during our experience. So this is a principle of macular hole surgery. Triamcinolone was injected, posterior hyaloid was induced, brim fluid was stained the ILM, and I usually did do the large ILM peeling to enhance the macular hole closure. Then I put gas injection. This patient, she is a woman, she has idiopathic macular hole. Her vision was 20/200 before surgery, and as you can see, she has a full thickness macular hole. And this is the 3 weeks after surgery, in which you can see the closure of the hole with some defect in the external limiting, in the outer nuclear layer and the ellipsoid design. However, it's healed, and her vision improved to 20/50. This is another case which I did it with 3 dimensions microscopy in Gwinety. I hope you have stereoscopic glasses so that you can see it good. So it's the same principle. You inject the triamcinolone. Usually, he is 10 years old. Usually, you have a tight posterior hyaloid, and it's not easy to induce the posterior hyaloid in young children. So with the triamcinolone, we are able to visualize the posterior hyaloid. We induce it, and ILM was removed with the aid of the staining by Brilliant Blue. Brilliant Blue is very nice and give you a very good staining for ILM. I did large macular access because really it is large macular hole. The vision was 20/200, as you can see, has even some chronicity in terms of disturbing of retinal pigment epithelium and outer nuclear layer. This is 2 weeks after post-op, and his hole is almost closed, and his vision returned to 20/25. So really, with macular hole surgery, with the advent of the surgical instrument, with the dyes that we are using, with the OCT for the follow-up, really give you a very good success rate in terms of vision and anatomical success rate. What about the complication? No surgery without complication. Complication can happen. The most common complication, especially in the older age group, is the cataract. peripheral retinal breaks, vitreous hemorrhage, hypotony and release choroidal and rated choroidal effusion and choroidal hemorrhage, superficial retinal hemorrhage, endophthalmitis. What about the vitreomacular traction surgery? Almost is the same principle as macular hole, but the controversial is in the interlimited membrane peeling, especially in the diabetic patient. Also, the vitreomacular traction has a complication, cataract, epiretinal membrane in 5.7, and also retinal detachment. This is the case of diabetic vitreomacular traction. She's 57 years old. Her vision was 20/30. And this one, I show different cut just to see how bad schisis that she has and how the fovea is pulled by the posterior hyaloid. So this patient, again, the surgery was done by 3-dimensional microscope. So the principle of the surgery, pars plana vitrectomy. This is 25 gauge vitrectomy. So vitrectomy, usually they have a partial PVD, and you can see the glistening membrane overlying the retina. And really, she has a huge cystoid macular edema. She has also active PDR, and you can appreciate some MVE, in which during the peeling of the posterior hyaloid, it gets bled. You can see the MVE now. This one is semi-regressed. So after induction of the membrane, shaving of the vitreous cavity, and we did laser because of the PDR, and usually these cases I inject triamcinolone because of the huge cystoid macular edema that she has. This is the OCT after her surgery, 2 weeks, and I get scared when I see this amount of subretinal fluid. But then it get regressed, but she developed lamellar hole. Her vision improved a little bit from 2300 to 20/125, and also she has glaucoma. So basically, really, the surgery, it is a good option to treat vitreomacular traction, and vitreomacular hole depend on our experience and supported by different studies. Now, what about the pharmacological intervention, what we call enzymatic vitrectomy? Mycoplasmin, thrombogenic mycoplasmin, it is a acroplasmin recombinant truncated form of plasmin. Is a proteolytic enzyme, which is equivalent to human serine protease. The microplasm can induce posterior vitreous detachment through liquefaction of the vitreous and weaken the adhesion of the vitreoretinal interface. You remember I mentioned about the adhesion nucleus between the interlimiting membrane and the posterior hyaloid. So it's acts precisely on this area, in addition to its vitreolytic effect. Now, with the microplasming using for releasing of vitreomacular adhesion, we have two good trials, which is MIVI-TRUST. The MIVI-TRUST, total of 464 enrolled eyes that received a single injection of microplasmin with a follow-up 6 months. At the day of 28 post-injection, they found that the eye receiving microplasmin exhibited a greater release of vitreomacular adhesion and macular hole, and presence of posterior vitreous detachment in comparison with those who received vehicle injection. And also, they showed improvement in best corrected visual acuity. And another study, which is OSIS study, this is a shorter study, include 220 eyes, almost the same finding. It's a release of posterior hyaloid with a closure of macular hole, compared with the patient that received the vehicle. And also they show improvement in the visual acuity. Both studies, they recommend the use of microplasmin with a success rate in these entities. Phakic status, age younger than 65 years, small adhesion, presence of full thickness macular hole, absence of epiretinal membrane, absence of concurrent retinal disease, shorter duration of VMT, transient outer retinal layer abnormality on OCT, macular hole size small. What about the use of acroplasmin in diabetic macular edema associated with vitreomacular traction? There is only one study. It is really a small study. It's multi-center, what we call MIVI study. They use different types of microplasmin attempt to release the vitreomacular adhesion and decrease the macular edema. Usually, until now, there is no conclusive result from this study. They said that some patients, their adhesion released and macular edema subside, but really there is nothing published in the literature. And also there is another study by Thrombogenics, which they call it phase 2 circle. It's evaluate also multiple doses of use of microplasmin to reduce PVD. The aim of this study to decrease the regression of the diabetic retinopathy. Still, it is ongoing study. What about our KKESH experience? In the past 2 years, we get the chance to have 6 injections in KKESH, and let me share with you these cases. This case has vitreomacular traction, and it is related to the idiopathic idiopathic one. And really, it is nicely shown the posterior hyaloid gets separated 1 month after injection. However, this case, this is a sad story. Actually, this patient, she has a full thickness macular hole in the left eye. She get operated, and the hole is closed, and she refused any type of surgery. Then she developed epiretinal vitreomacular traction with foveal distortion, and she is symptomatic. We offer for her microplasmin, but unfortunately, her vitreomacular traction did not release. Until now, she is refusing the surgery. The other 4 cases that we did, it is diabetic macular traction. This case, the posterior hyaloid get released, and then he developed a lamellar hole in which the visual acuity get worsened. This case, vitreomacular adhesion with edema, the posterior hyaloid get released. Still, he has macular edema, and he is now treated with intravitreal injection. Another case with the same scenario, the posterior hyaloid get released after injection, but usually the releasing is not after the 30 days. They took a time to release, and that's why we are not relating the success of releasing of posterior hyaloid to the microplasmin. This is the case of vitreomacular traction due to diabetes. He received the microplasmin, but actually after the injection, the macular edema get increased. We offer him several intravitreal injections, then posterior hyaloid get released. And this is the last one after combined laser and intravitreal injection. The adverse effect of microplasm is vitreous floater, photopsia, conjunctival hemorrhage, blurring of vision, increased intraocular pressure, retinal tear, cataract, macular hole, retinal detachment, and reduced visual acuity. So the benefit of ocroplasmin diabetic macular edema with vitreomacular adhesion is really doubtful in diabetic patient. Thank you very much. Why? Because in diabetes you have abnormal vitreous, and usually they have partial PVD. And also, sometimes when you give microplasmin, the separation does not happen at the cleavage between the internal limiting membrane and the cortex. So it may be some of the collagen fibers remain on the surface of the retina, and this may act as a scaffold which enhances the neovascularization and macular edema. So maybe it will increase the severity of diabetic retinopathy. Also for diabetic vitreous is glycated vitreous, so you don't know the efficacy and susceptibility of this pharmacological agent in the vitreous. So it's really need adequate patient selection, probably adjunctive compound like hyaluronidase to able to separate the collagen fibers from the retina. And it need really things to study and before prove its efficacy for especially diabetic retinopathy associated with vitreomacular adhesion. Just to share with you, this study, which is done by the primary investigator, Dr. Igor Kozak, and the listed co-author, and I presented in ARVO in the last 2 years. This is showing the comparison of surgery, intravitreal ocroplasmin, and observation in vision-decreasing vitreomacular traction syndrome. And the purpose of this study is just to compare the clinical outcomes of parsimonic vitrectomy, intravitreal injection of ocroplasmin, and observation in the management option of symptomatic vitreomacular traction. So it was a retrospective study, and this is joint study between KKESH and out of Salt Lake City in USA. The study period between 2013, it's almost 1 year. And the vitreomacular traction was diagnosed by spectral OCT, and the main outcome measure included visual acuity, the logMAR and FMT released, and not released at the baseline and at the last follow-up. And based on the management, the cases were divided into 3 groups: observational, surgical, and microplasmin. So the result, we get total of 51 eyes of 50 patients. The surgical group included 11 eyes. The acroplasmic group included 8 eyes, and observational group included 32 eyes. The mean age for surgical group, 56 years. The baseline visual acuity logMAR of 0.81. The visual acuity at last visit was the logMAR 0.64. And the mean follow-up was 10.27 months. For the acroplasmin group, the baseline visual acuity was 0.5. The visual acuity logMAR at last visit was 0.52, and the main follow-up was 3.87 months. However, in observational group, the mean age was 66.3 years, and the baseline visual acuity logMAR was 0.58. The visual acuity, the logMAR at the last visual visit, was 0.57, and the mean follow-up was 6.27. We found that the change in the visual acuity between the baseline and the last visit was significant in the surgical group with a p-value 0.041, and was non-significant in the acroplasmin and observation. We also compared the group management with the VMT release, and we found that VMT get released 100% surgical group, in the acroplasmic 62.5%, and in observational group was 31.3%. And we found that the VMT release between surgery versus observation was statistically different with the p-value, with the significant p-value. And also with the surgical versus acroplasmin. However, there was no difference between the microplasmin and observational group. We also studied the prognostic factor, the lens status with the VMT, and we found that those with the phakic eyes, the VMT get released more than in pseudophakic eye, and this is applied in all groups. However, we studied the lens status with the visual acuity, and there was no difference in the visual acuity with the presence or absence of the lens. Another prognostic factor we study is the type of VMT adhesion, and we found that the broad VMT have a worse visual acuity compared in all the group, observation, surgery, and acroplasmin, compared with the patient that had focal VMT. However, the difference was insignificant. The type of VMT adhesion also studied with the VMT release, and we found that the eyes who present with the focal VMT, the VMT get released more than those who had a broad VMT, and this is applied in all groups. So the limitation and conclusion of our study that surgical intervention results in complete release of VMT with improvement in the visual acuity. Intravitreal, acroplasmin, and observation have similar rate of VMT release with little change in the visual acuity. The release of VMT might be affected by the lens status being more in phakic eyes, and the broad VMT had the worst prognosis, and actually this is equivalent to what published previously. However, the limitation of our study that the natural history of our cases was incompletely defined, therefore the criteria for surgical intervention remain uncertain. So in conclusion, the clinical course and the natural history of VMT is not yet clear, therefore the management options are variable and different. Observation could be, especially if you have a good visual acuity, could be an option, but not always. Enzymatic vitreolysis, acroplasmin, can be used in certain cases with promising result that may spare the patient risk associated with surgical intervention. However, remember, the microplasmin, it is high cost, and see if it is worth to do it in your cases or no. Still, the surgical intervention remained the standard care for vitrectomy traction syndrome management. Thank you.
Thanks, Saba, for this nice presentation. I'm sure there are some questions. I would like to make a comment about the classification that you presented, which is something that's been proposed several years ago and has never been very much implemented in the community for the simple reason that it was, according to many and to me also, very company-oriented. Everything came out when ocriplasmin was brought on the market, and they tried to convince us that vitreomacular adhesion, which is actually a normal anatomical findings in all of us, was a disease. So I would not really suggest our fellows to really keep this classification in mind. It is good that it's tried to do a new classification, but I think there is much more to do about it. Yeah. They also didn't consider the schisis of the cortex, which is a very important problem. Yeah. In fact, you show some of the diabetes very nicely, where you could see very clearly the schisis of the vitreous, and so in those cases, for sure, ocriplasmin would not be the most indicated treatment. Another another comment I wanted to make, you didn't mention probably for lack of time, but macular hole treatment nowadays, also these new flap techniques are very much used, especially in larger holes. Maybe we should do a focused lecture about it next time, but just to keep you updated with what's going on in the surgical retina. Are there any questions? Dr. Divi?
Thank you so much for this nice, really, and overview of the VMT status in our patient, as that now we observe it increase with the advent of OCT, which is show us more pathology than without expected. I have two comments regarding to the patient that having diabetes with VMT, and that being, get high to enough, and did you this surgery and it settle down. I think we need to interfere with this patient before we get to this because most of the photoreceptors being affected, so the visual recovery in this patient not as we do it as early as possible. The second thing is about ocriplasmin. The cost of ocriplasmin is 17,000 riyal Saudi. The surgical intervention might be cheaper than this. I will keep it for the patients that might not able to get to the surgery for any reasons, either general status of the patient or other. The other things that the side effect of acrylazmin is not clear for most of the people. It's like an chemotrypsin, It might be ended by having weak granules, and this is maybe another issues that need to be dealt with. So when you are having this opportunity, try to think about how much that the patient will gain from. Other issues, the toxicities of acrylazmin is not that clear enough till now. There is transitional times where that photoreceptors being affected that recover, but we are not sure 100% is that really the status after years or not. So VMT is really an issue now. We need to deal with it in a practical way that help our patient, especially with the advantage of small gauge vitrectomy, which is make the surgeries more easier than before.
Yes, I agree. Yeah.
Sure. If you look also in the MIVI-1 study, the incidence rate of retinal detachment was 0.9, which is very comparable to what vitrectomy nowadays is, around 1%. So there is really no advantage in ocriplasmin considering costs and complication rate. Also, the unexplained vision loss, there was 0.4% of patient lost vision without any clear explanation. That needs to be taken into account. Sausan?
Thank you, Saba. Very nice overview. I think vitreomacular traction has always to be taken into in context with whether the patient has epiretinal membranes or not, whether the patient has diabetes or not. For sure, I would think that ocriplasmin is not the best for the diabetic edema, and ocriplasmin has been shown to have, following the treatment, some dissolution, lysis of connective tissue that sometimes cause subfoveal detachment. But there is a lot of talk nowadays about just pneumatic release of the vitreo and I wanted to hear from your experience, because it seems like the results are as good, if not better.
Yeah.
So
actually, it is really very small case series, and the idea behind it is just a mechanical release of PVD. Yeah, so for me, I didn't do it, you know. I just maybe Abdullah, he raises his hand. It's just a small case series, and I'm not following it. Yeah.
Because of the adhesions, exactly, because you have attractions everywhere, but it may be reasonable in patients who have age-related simple and probably focal detachments.
I believe if you treat something, you have to get it out. You have to cut it. The abnormal things, you have vitreous. Take the vitreous out. Because if you release, you don't know how the release happen, whether really you are on the cleavage between, especially if you are, as you mentioned, if you are deal with the entity like diabetes or any type of vitreous cases, even in retinal degeneration and myopia and every type of cases, you don't know the cleavage. So if you give a microplasmin, it might affect also on the collagen fibers of the internal limiting membrane and can spread to the photoreceptors and the neuron cells and can cause damage. Exactly. Yeah.
So.
For me, I don't have just a small. If anyone can answer this question, because really I don't have experience with the nematopexy and.
But with pneumatic, it's simple a mechanical effect. If there is a focal traction, in theory, you are displacing the vitreous, so you are assuming also the vitreous could attach. The problem is that it's been shown it works. I agree kind with Saba saying that it is an uncontrolled way of releasing a problem. I think the patient should be informed that having this may create traction in another quadrant. Everybody sees when it does pneumatic retinopathy for retinal detachment that you can create a break in the inferior quadrants if you treat the superior break. So the same may happen also there. So very careful selection, no myops, no lattice, and for sure very good counseling of the patient. But some of the effects of the microplasmin is also due to mechanical traction release, So for sure there is a rationale behind, but it is uncontrolled and it can be dangerous for a patient for the reason I just mentioned. So I agree that if you have a system which gives you small trauma, like small gauge surgery, the complication rates, retinal detachment in that type of elective is basically around 1%, if not less nowadays. So why don't go for an absolute 100% resolution of the problem in a controlled way?
And especially it can induce retinal breaks and the complication for nematoretinopathy. So it's really... And also for diabetic macular edema, I mean, with the frequent injection, the membrane gets released, So
True.
It's really mainly related to the mechanical effects of the
I agree with everything
procedure.
that you said, except that there seems like in the European and the American meetings that there is more and more a move towards try air first. This is why I asked whether you have experience with that.
Basically dead.
Yeah, I know.
It's basically dead. It's just been revitalized at the moment by thrombogenics as a fibrinolytic because it's a plasmin. So it gets, if you inject it, it would work like a lysis of the fibrin clots. But there is no, from the point of view of the use in vitro macular attraction, is actually dead. Abdullah, you were there.
Yeah. I would like to thank Dr. Saba for very nice detailed lectures about the vitromacular abnormality. I'm asking about especially diabetic patients who are having diabetic macular edema with what seem to be adhesion versus traction, because there is structural changes. Is this due to the diabetes or the traction itself? My question to you, what's your approach to that and how do you...
This is very good question, and really I like it. And usually I'm teaching the fellow about this because sometimes you have a combined mechanism. You have a macroangiopathic effect of the diabetic process itself, and you have the abnormality in the vitreoretinal interface. Usually I take the patient as a package, clinical examination. If you see a leaking microaneurysm by fluorescein, if you see visible microaneurysm, if you see the OCT patterns, because telling you how the vitreoretinal interface, really it is get the effect on the fovea, or there is some intraretinal cyst which is related to the diabetic process. So usually if there is a combined mechanism, I will rather start with the injection, because as I mentioned before, the injection will calm down the diabetic process, the leaking and these things, and also there's a chance for aperital membrane. But if there is, I reach the state in which the OCT typical show me a foveal detachment, like a focal or broad, sometimes I'm using the fluorescein angiography just to be sure there is no, the leaking is from the traction, not from the microaneurysm or from the telangiectatic vessels, then I will go for surgery, and I will say this is a purely VMT. And I think I presented this lecture before, because really sometimes you get, this is whether we go to, usually I start with the injection. Yeah.
Samar?
Yeah. Thank you, Dr. Sabah, for this presentation. Really, you made it very clear for us that chemical agents doesn't work as what it was proposed to be at the beginning. However, I have just one question. For us as an anterior segment, we got multiple times, referral for cataract with Avastins or so on. Do you think that there is like an overuse of Avastins in some cases? Overuse, yeah, in preventing edema, and this might facilitate the traction that you're seeing nowadays?
In theory, repeated injection can increase this chance for separation of epiretinal membrane. It helps us, But for overuse, I didn't get what is the meaning of overuse.
I'm saying that it starts to be every patient who have. There are some surgeons that think that if you have pre-existing edema and the patient is undergoing cataract surgery, so please give an injection, regardless of you obtained a new image or not. Just do it and give a injection.
When they send the case, depend on what? On a clinical examination?
Yes.
And there is macular edema?
Yes.
Yes, I think this is good, because the intraocular surgery, it will enhance the macular edema. So it's better for the patient care to give him injection.
Yeah, but this will not affect if there is any also pre-existing VMT. It will not.
No, it will not affect. No.
Okay.
No, yeah. But maybe your question whether the cataract surgery it affect for it's different things.
Yeah, we know that it
because there is what we call Irving-Ganz syndromes, and sometimes you have them concurrent macular edema from Irving-Ganz with the macular edema. Yes, and that's why the Avastin, it will help, by the way, not it will increase.
I think to just make a little comment to what you said for anterior segment surgeons, right? I think you should be sure there is no fibrovascular proliferation when you do your phaco associated with Avastin. Because if there is no fibrovascular proliferation, it's very safe, as Saba said, to inject. Actually, it helps, it's better. You protect your macula in the period of the surgery, which fluid can increase. But when there is fibrovascular growth, and I'm talking about PDR, maybe that you have not seen properly, this injection can create problems, because there is always a fine balance in the eye between the vascular endothelial growth factor and other factors. Once you downregulate the VEGF, you upregulate the others, like connective tissue growth factor and all these that are fibrogenic factors, and you can have actually increase on the traction. I had sometimes patient injected by medical retina people when I was working in Europe with PDR, like 10 injections. And then what you find out is that they increase the traction, they come with traction retinal detachment. You cannot actually separate the alloy from the retina because of repeated injection. The same you can see if you leave an anti-VEGF pre-operative and you do not operate the patient. After 10 days, 2 weeks, you will see that this adhesion becomes stronger. So I think for the sake of your question, if you want to inject and there is no fibrovascular component, it's very good actually. And if there is some fibrovascular component, you better consult your colleagues.
So are you suggesting to change the standard practice that we need to get an OCT image before injecting Avastin to these patients?
I think if you get an OCT image, it's better, because you are doing a better assessment of the patient and you see if there is traction. And also a very good detailed fundus examination to see neovascularization.
Okay, so
and what stage of neovascularization is there? Is there fibrosis? There is no fibrosis?
So we'll take it as yes.
When it is too complicated, I think you should request a consult from your colleague.
Okay, perfect, Thank you.
Okay, thank you, Dr. Sabah. One comment regarding the question of Dr. Samar. I think Dr. Nicola Ghazi, he looked at those patients after Avastin injections, and he noticed some of the diabetic patients, they get their VMT released after the Avastin injection, secondary to the mechanical effect rather than the chemical effect. The second comment, I think so. I think it's beneficial in after cataract or during the cataract surgery to inject those patients, keeping in mind that you don't have fibrovascular proliferation as mentioned by our colleague. The second question, the second point regarding the ochraplasmin. So we don't know a lot about the toxicity of ochraplasmin, but some of the paper shows that ARG, some of the cases they have the ERG after ochraplasmin, they see a lot of significant diminution of the function of the retinal function after the ochraplasmin. Some of these papers shows like a transient process, but we don't know exactly the toxicity. So I have the chance to try in 2 or 3 patients, the diabetic patient with VMT ochraplasmin, but it didn't work. So I think ochraplasmin is an option in focal VMT idiopathic type, not diabetic type. Thank you.
First, Marcos. Yeah.
Okay, thank you for sharing this interesting topic. Our experience, my previous hospital, we were included into the clinical trial, MIBI trial, so we were working there. And I was really shocked to see your numbers because our numbers were 0. We used 9 ochraplasmin in 9 patients. 6 of them were included in a clinical trial, and then no injection works. So my question, it seems that probably there is any shape, or special shape of some of the profiles of the OCT that can proclaim to be
the recommendation
better working
is focal one. Yeah. By the way, also for our cases, only 2 get released. Because the release should be 28 days after the injection, right? But the other 4, with the repeated injection of the anti-VEGF, they release. So we consider it as a failure. So we get only on 2 out of 6.
Yeah, because it was so the numbers 65 is way high. You know, there's an issue. There's some hospitals. They are the hospital I'm working there. The other hospital is as big as us. They achieve a 50% of success, and even they come people from the clinical trial to see if we are doing something wrong, and they were reviewing all the procedure, all the injections. Myself, I do 2 procedures, I do injections to the patient, and I don't know why, but we achieved 0. And we were included into the clinical trial. So
bill twice is convenient.
Regarding the macular edema post-cataract surgery, it has been shown that even diabetics, even without diabetic macular edema, they have more edema than normals. That's why I think the patients, diabetic patients with macular edema going for surgery, or who have been treated by the edema, to have intraoperative injection. I think this is very good. And just to make a note that give the intravitreal anti-VEGF before aspirating the OVD, the viscoelastic. This will have very good counter pressure instead of having the injection in a softer eye.
Sure, it's a technical thing. Sorry, one more time.
There is a clinical trial doing now anti-VEGF as a prophylactic before doing surgery.
But
now
everybody agrees about that. I think there was something there. Last question because we're already out of time.
Okay, thank you very much. I think we need to be careful with ochraplasmin. Remember, ochraplasmin belongs to the same family to the alpha-chymotrypsin. Alpha-chymotrypsin used to be used by the Professor Barraquer in Spain to perform total cataract extraction. Okay? All right, so there is a paper about the total luxation of the nucleus after cataract surgery or before cataract surgery after injected ochraplasmin. And so far, finally, I didn't have any paper, and there are several about the huge complication after ochraplasmin, because laminin is not only in the IRM, it's just in the entire retina. I think we need to be careful with this enzyme.
Yeah, great.
Okay. Thank you very much, everybody. Thank you, Sarah.
Thank you.
This is the ice cream. Hey, congratulations. Your speech was fantastic.
Thank you.
I really enjoyed you. You were like the chief, like talking very.
I'm always like this.
No, fantastic. Really,
I'm always like this. Give it to the guy inside.
Professor Mura? Professor Mura? Ah, where were you?
Give it to the guy.
You look like a gentleman there, right?
You look like a gentleman.
This is the proteome enzyme.
Sure, it is a
Yeah, we need to be careful.
proteolipid enzyme.
Yeah,
So you just
Right. What are you going to do? Hi.
It's a little bit difficult. I realize this. It's a little bit difficult. Really? I hope I'm not doing. When are you starting?
No.
طشت شيء ولا تشكر
الله يرضى عليك تسلم
جاهز ما تقول
الله يكرمك تسلم
ماشي دكتور
عساك بس هلالي بس
اي هلالي
يعني تعيس اليومين هذه الله المستعان
عشان ما يزعجك
اي يا ليت ايوه ممتاز ممتاز الله يكرمك الله يرضى عليك everybody's here. Residents from the ER, Ahmed Jalud. All the team are here. Okay. الحين just 1 minute and we'll start, okay? Can you just make sure that everybody's in here? ما كثير بس لأن البطارية بتخلص وابغى Okay, shall we start? Okay. Okay, so the quiz is going to be 6 questions. Whoever gets 5 will get the full mark. Okay. Yeah, let's start. I think, yeah. Okay, so this is a 23-year-old male. He just came for a refractive workup, and we saw this in his fundus exam. Is the image clear? Very clear, okay. So describe the finding you see. Mention one ocular complication that may arise in this situation, and possible systemic associations. And what are the possible reason of death in this kind of patient? So I'm going back to the image for those who didn't see it. Okay, shall we move? Okay, the second case. This is an 80-year-old male. He's complaining of poor vision for a long time. He had a history of brain tumor. And there is this finding on his fundus exam. This is an OCT image of this lesion. So describe the retinal finding you see and mention the possible systemic association. Okay, we'll move to the third case. This is a 6-year-old girl, and she complains of poor vision in the left eye for a long time. So this is the case I saw, and this is the best image I got. So we're gonna try if we can show you. Okay. Pointer. Is it clear? Okay, this is the left eye, and I'm going to show you the Optus photo of the same eye. I know the quality is not very clear, but you can see that there are some changes in the periphery and the blood vessels. I'm going to show the other eye. Also, there are findings that you should look carefully to. Okay, so look at the blood vessels at the disc area. There are some clues there. So it's a 6-year-old. She has poor vision for a long time. And she came for a routine exam, and we saw these changes. It's a girl, actually. Okay. So this is the left eye. And this is the optus. And this is the right eye. So 2 differentials, most likely diagnosis, and the possible reason of death in this case. Dr. Sousan, she knows most about this. So there are 2 main differentials, and something that makes you choose which one of them is the most likely one. Okay, 4th case. This is a 71-year-old lady who's not known to have any vascular diseases. She complains of chronic fatigue and proximal weakness. And she presents with no light perception vision. The other eye is totally normal. So this is the exam of the right eye. This is later in her presentation. So this is her fluorescein at 15 seconds. And this is 19. And then on 21. Unfortunately, this is Optus, and these are cases I saw in the clinic, so this is the best I could get. And I think it's very clear from the sequence what's there. So what is the abnormality in her FA? And mention the most likely diagnosis, systemic association, and because it's a serious problem, what's the most, or the possible reason of death in this case? So I'm just showing you this one because it's you can tell from the clue and the numbers here. But other than this, I don't think you need much. Okay, case number 5. This is a 42 years old medically free who presented with a recent drop of vision with no history of trauma to the left eye. Again, her right eye was normal. Okay, this is her fundus exam. And this is the OCT. So, name the abnormality seen in the macula, mention 2 differentials, and the most likely diagnosis. OCT again. طيب. Okay. Last case. Okay, this is a 19-year-old male, and he had a vitrectomy with the silicone oil. And he's seen in the first day post-op with normal IOP. So, okay, there are multiple bubbles here, and I want you to tell me what are they. Okay, try to look in details in all parts of the eye and tell what bubbles you see. Again, if you answer 5 of 6, you get the full mark. Keep this for another 10 seconds, and then we'll end. Dr. Susan, shall we repeat the answers, the questions again? Okay. طيب, okay, we'll go fast through them, okay? First case. I'll give you 10 seconds in each slide, then in each case, and then we'll move. Second case. So this one I'm going to take longer time just for you to look at the images. And it's, again, 10 seconds, but just... the last one, the fourth one, again, this is 15. These are the questions. Just mention what you see. Okay? I'll stop at the first one, but we'll start collecting. Because we still have a case presentation and we don't want anybody to get bored. Shall we like have volunteers, or just tell the answers directly? Okay. Okay. طيب Dr. Khan, can you tell me what's the answers here? Okay. First case. So describe the finding. What do you see in this case? Okay, what are the ocular complications that you... Okay.
Ocular complication, CNVM.
Okay, and possible systemic association?
Ehlers-Danlos syndrome. Pseudoelasticum.
Paget's. Okay.
Paget's disease.
Okay.
What is the possible reason for death? GI bleeding.
GI bleeding, excellent. Yeah. Yeah, absolutely. Please.
Okay. What is peculiar about CNV in angioid streaks? We have choroidal neovascularization in angioid streaks, right? It's one of those causes. It has a... Okay. Are they sub-RPE or are they subretinal? Sub? Who says sub-RPE? Who says subretinal? No hands in either case? Who says subchoroidal? Okay. They're subretinal, okay? So angioid streaks are breaks in Brooks membrane, okay? They're a rigid Brooks membrane, and therefore when it cracks, it's like in myopia. They're classic membranes. They go through the RPE, okay, and are under the retina. So they behave like classic membranes. And the thing about angioid streaks is that they are as bad as CNVs in AMD, okay? So while myopic cases respond relatively nicely to anti-VEGF, although many will need more than one injection, the angioid streaks membranes tend to grow. And so therefore, if you have a patient who has angioid streaks and choroidal neovascular membrane, you need to give an injection every 4 weeks. And if you want to do a treat and extend, you have to very, very carefully monitor. This is not somebody that you're going to get treated and then say, okay, get an appointment. Highly, okay? And they always come back worse, always. So they're very, very aggressive. So that's what I wanted to stress. They're aggressive membranes.
Okay, second question. Any volunteers?
This is retinal astrocytoma associated with tuberous sclerosis. Usually these patients have some systemic manifestation, CNS, cardiac rhabdomyoma, renal dysfunction, and this is most likely the cause of death.
So usually it's you mean the astrocytomas, right? The malignant astrocytomas.
Retinal astrocytoma.
No, I mean
the cause of death.
The cause of death.
Yeah, they usually have multiple CNS abnormalities. One of them is malignant.
Okay.
Yeah, cardiac rhabdomyoma, renal dysfunction.
What about the systemic associations?
Yeah, they have cutaneous manifestations. Ashley.
Okay, the third.
Do you want to talk to them about how it looks on FA?
I have no images for the FA. This is
Okay.
the problem. That I was gonna show.
What do you think it looks like on FA? Think. FA. Why would it autofluoresce on fluorescein? On fluorescein, how does it look? You inject fluorescein, how does it behave? It leaks. Okay? It may look white, but it leaks. All right? It's a tumor that leaks.
Okay.
It may have a little bit of autofluorescence, yes, but it leaks.
For the third case, anyone who wants to volunteer? Ahmed Dail? What do you think? Yeah.
I'm not sure, honestly, but is there like microaneurysm or?
So what's the if we go back to those images here, what are the things that that strikes you?
There is exudate.
Mhm.
There is hard exudate.
Mhm.
I think there is some telangiectasia.
Okay.
I'm not sure if there is macroaneurysm.
So the reason for the poor vision is this macular scarring from the chronic exudation. And so what's the clues here? I don't want to, take much time in this, but you have mainly two differential diagnoses. Can you tell me what they are?
Maybe codes or FRAM.
Okay, what makes you think that this is coats and what makes you think it's FRAM?
Codes because it's unilateral, though it's in a female. Usually it's more common in male.
Yeah, but I showed you the other eye, the fluorescein here.
Yeah, it is normal.
You think it looks normal? Anybody disagrees?
Maybe some leakage at the disc.
I know it's not very clear, but I mean, if you look at the disc itself.
Yeah, the projector if you see this thing here and this thing here, now is this vein or artery? Vein or artery?
Vein.
Why?
It is larger.
I forget the larger. كم مرة أقول لكم forget the larger. What makes you think that this is artery vein? They're more hyperfluorescent. Both vessels are filled completely. None of them is in laminar flow. They're filled homogeneously. This one is brighter than this one. This four is a vein. Okay, I don't want to hear if this is larger anymore, or please. So you have these little tiny things. They're difficult to see from far. And one here, as doctor, and one here. You see how this vein is brighter than the artery? Yes? And you have a little bit of I think this is an aneurysm. It's harder. I believe it's an aneurysm, yes.
And then again, the thing that goes against it is that, first of all, the question itself gives you the clue, because I'm mentioning that there is a systemic association and reason of death, okay? So, and the other thing is that usually it comes, as you mentioned, mostly in males, and usually it's unilateral, okay? So what's your explanation for the possible cause of death?
Usually if it's FRAM, so they will have cardiac disease and pulmonary stenosis.
Okay. Anyone cares to elaborate more on the cardiac findings with FRAM? I think it's, perfectly stated. So the fourth case, Hamid. Okay, what do you think?
There is a delayed choroidal arterial filling.
Mm-hmm. So what do you think possible causes of this condition with the history we took, we mentioned? She has no systemic vascular diseases, and she's complaining of chronic fatigue. What do you think this might be a presentation of?
GCA.
Okay. And with what's the other differential you think about other than GCA?
Ophthalmic artery occlusion.
Yes. So the finding here, if you can, I'm going to go back to the fluorescein. So you can see that there is even not much of choroidal filling, and there is no light perception. So you're thinking about central artery occlusion, but there is another explanation. Anybody cares to tell us?
Ophthalmic artery occlusion.
Okay. And for this reason, we think it's most likely GCA, and this is actually a patient that went and had been investigation, and it turned out to be GCA. And what's the most common cause of death in those patients?
Stroke.
No, it's coronary artery infarction. Okay. طيب أحد من الفيميل سايد؟ سارة ريم. هذه التركة انك تقولي اوكي وبعدين.
طيب. So the abnormality in the macula, there's exudative retinal detachment under the macula.
Okay. This is what I want. I know there are some findings that we saw in the OCT, but this is what I want you to mention. Okay.
And the two differential diagnoses, optic nerve pit and optic nerve coloboma.
And the clue here is the?
There's like the pit, it's obvious, inferior temporal.
Okay. Here,
yeah.
Huh?
Yeah. So the diagnosis is optic nerve pit.
Okay. طيب مين وده يتبرع؟ So I'll just go ahead. So this is a case patient who had RD repair, and then first was of day he had this air bubble on the ICU, and then symptom. I know. I'm just concerned about this. If we get this, we'll get the next one. It's not very clear. Okay. Thank you very much. You're welcome. تفضل. تفضل. Yeah. That's true, but I mean, in this case, I'm telling you some clues that the patient had, and she ended up being. This is the diagnosis. But you can mention what you mentioned. If you have the explanation, you'll get the mark. تفضل فيصل. Why not? Okay, so we'll take 10 minutes and then we'll convene for the presentation, okay? هلا هي. كان كوز بس انه malignant chances of
طبعا صح.
بس انه if you mentioned this.
I mentioned cardio. طيب نفس ما
ثاني كمان؟
لأنه اشتغل معي الفريزر. اشتغل كيف
بس الداونلود حسب بس هو تحميل بالبيت فقط باليو اس بي.
دائما في اي انا اخاف اتغير اللايوت عشان انت بفيزي ما يتغير، باوربوينت يتغير.
البداية عندك دكتور؟
اي
لا ما بيطيح خلاص ثبت. ثبت. سجلته بايميلك كيف مش هطول ساعه لو بدك ترفع شيء على الموقع تفتحه لايف اذكر مكان في الدكتور اعرف تعرف عليه البلاستيك هو الوحيد اللي كان لا صح هو الوحيد اللي كان يستخدم كان مستخدم بس كان عرض جذاب حلو الحركه اصلا حركات الانجليزي جميل وجذاب دكتور تحتاج الكيبورد وهذا كل واحد ولا تفريق لا بس عشان اللابتوب دكتور شاركت اليوم بشيء رسمي صح ولا؟ لا ذاك مكان كريس وكانني اذكر ذكروا اسمك والله ما ادري يعني ما حضرت انا كنت في الرياض انا رياض روتيشن لا ما شاركت شاركت بصورتك اي عشان كذا ذكروا اسمك ورود اي ذكر اسمك استعرض المشاركات بعدين كرروا الفائزين بس جميله الرسمه الاخيره دكتور ركان خطير عجيب صراحه 10 ساعات ما شاء الله شيء رائع صراحه فني ما له علاقه انا اعرف لك واحد والله مو متعلم جماعه رسام عندنا واحد في الوظائف كان خالد سهل ترانسبورت الله رسام خليه يوريك رسمه يوريك شيء رسام صفين شباب الحمد لله طبعا هذا مين؟ شو مثل جميل اتكلم فرنسي ايراني اتنقل ماخذ البير ماشي الله يعطيك العافيه اهم شيء والله حلو والله جميل
Bismillah. Should we start, دكتور؟ طيب. السلام عليكم ورحمة الله وبركاته. My name is Hamoud Mohammed Ataibi. I'm a second year resident at King Khalid Eye Specialist Hospital. Before I start my presentation, I would like to thank Dr. Adil Agil for his kind supervision preparing this presentation. The title of this presentation is it circumscribed choroidal hemangioma? Earlier this month, we had in the emergency department a case. She's 33 years old, female, medically free, complaining of sudden onset of blurry vision in the right eye for 3 weeks, and right-sided headache, tearing, redness, and photophobia. She sought medical advice, and they told her that she has an RD in the right eye. The history taken by the resident there. She's currently taking oral contraceptives. The BMI is 37, no history of body weight gain or trauma or weakness. Slit lamp examination by the resident it showed in the right eye, the vision is 20/200, and in the fundus there is clear medial disc edema, superior temporal, subretinal fluid, and submacular fluid. Left eye is within normal. So how will you investigate the case? So we'll start with send patient for OCT, fundus photo, FFA, B-scan. They did B-scan, and it turns out that according to the ultrasound technician, that the patient has choroidal lesion and secondary RD. We'll see the pictures. What do we see here, Abdulaziz? Excellent. This is could be okay. This is maybe this might be. It's not clear here. Maybe in the screen it will be. What do you think about the choroid? Can you comment? Anybody can comment on the choroid? Thickened, right? Okay. So we have thickened choroid and RD. This is what we can see. طبعا investigation, we did visual field, generalized constriction, color fundus done, and OCT. The initial impression was exudative RD secondary to choroidal mass in the right eye, query circumscribed choroidal hemangioma. Patient was admitted, then they did A scan, ICG, color fundus photo. These are the photos in the right eye. We can see here that the fundus, this is top-con photo, showing what we can see here, Mohammed. Excellent. It looks good. Excellent. Looks like choroidal folds with hyperemic disc, right? Yes, exactly. طبعا this is Optus photo. We can see here superior RD. This is the FFA. Sorry, I didn't take many cuts of the FFA. This is what we can see here. Anybody can comment? Abdullah Khan. Excellent. First, which eye? Okay, excellent. Which is the vein and which is the artery? Excellent. The larger. Okay. So this is another cut of the FFA. This is the OCT showing an RD superiorly. Left eye. This is okay. In the OCT. So anybody can comment. The Umar Abbasi. Okay. You want to comment, Sector?
And you see the borders of the forearm, and you see the posterior, the scleral junction.
No.
You need enhancements that
Okay. Okay. طيب, move on. Left eye. This is the top of the left eye. It looks normal. This is the FFA of the left eye. Again. And the OCT, it looks dry macula, normal looking macula. The next day, after admission, further history and examination by the fellow, there is gradual decrease in the right eye for 1 month, left eye for 1 day, associated with photophobia, no history of tinnitus, skin changes, or contact with TV. This is the fellow examination. 2300 in the right eye, worse than the day before, ACE reaction +2, 2030 left eye, ACE reaction +1, both bilateral exudative RD. B-scan again by a senior ultrasound technician. It showed multiple serous RDs, OD, and more than the left eye. His impression is to rule out uveitic changes. The OCT showed exudative RD both eyes and FFA hot disc with multiple pinpoint area of leakage. This is the right eye after 1 week, what we have in track here. And this is again the Optus photo showing superior RD. The left eye, this is multiple RDs. This is the left eye again, Optus photo. We can see, yeah, very obvious. The FFA of the left eye. So we have here, in the last cut, we have like leaking. Yes. Exactly here. Yes. And then it's increasing in size. Sorry, intensity. Staining. Pooling. Pooling. Yes.
Very regular. Most of the hyperfluorescence is towards the edges,
Yeah.
where the fluorescein accumulates at the edge of the lid. So is this a sub-RPE or a sub-neurosensory retinal?
So, neurosensory.
Okay, proceed.
Sorry, why?
I don't know.
This is sub-neurosensory, not sub-RPE. I'm sorry?
Intensity.
intensity with well demarcated from the beginning. If you go back to the first one, okay, this is not very well demarcated.
Yes.
Right? And you have pinpoint hyperfluorescence, is not as well demarcated as you'd expect in a PED. Besides, having a PED in medical tracking of this size is like, wow, you know, I mean, this is important.
Yeah.
Okay? But so you have, and you don't have an increase in intensity in the center, right?
Yeah.
So most of the intensity of the fluorescein that you're seeing is towards the edges of the blood.
Exactly.
So that's a neurosensory retinal detachment.
Thank you, Doctor. Yeah. So these are the images. So the diagnosis was made as VKH. What is VKH? Stands for Focal Koenig-Harada syndrome. Yes, Doctora.
Sorry, I want to interrupt. Look back to the very first right eye, the one that people thought of as each. You're gonna have to teach me how to do the slides.
Okay.
Dear Head, no, please. Wait.
Yeah.
The fluorescein angiogram
Sure.
of the right eye.
Sorry. So this is.
There. Okay? What would you expect in a choroidal hemangioma? What make people think of a choroidal? Early hyperplasia. Watch out. Okay, watch out. So why do people think this is a choroidal hemangioma?
From the B-scan report by the junior ultrasound.
You don't have something that shows choroidal hemangioma here, huh?
Yes.
So it should not even be considered. So what is it that you see here? Describe. What do you see on the fluorescein?
So.
Explain that
Yeah, sure. Sure. So we have a hot disk with a pinpoint leakage in the macular area, and pinpoint hyperfluorescent of the macula. تمام.
Yes. And okay, بعدين the next one. You cannot base your diagnosis on one frame, so
Yeah.
you have to have another frame. So what's the second frame?
This is what.
This is a minute later. What's happening here?
So a minute later, we have increase in the intensity of the fluorescein with a hot disk.
You basically have a hyperfluorescent disc that
Yes.
has leaky margins or blurry margins,
Exactly.
possibly staining. Okay, and you also have an increase in the intensity and perhaps a little bit fuzziness on every little pinpoint hyperfluorescence that you saw before.
Exactly.
If it was choroidal hemangioma, what would you expect? How would it look in the beginning? In the beginning, it's a choroidal hemangioma. Where does it start to hyperfluoresce?
Choroid, at the choroid.
What would you expect?
It will be hyper.
Hyperfluorescent pinpoints?
No, diffuse.
Diffuse? على حاجة تكون diffuse. What are you going to see? It's a choroidal hemangioma. What are you going to see? Later on, that's true, but do you see the vessels? You see the cavernous spaces, right?
Yeah.
You see lines, and you see plaques, and you see cavernous spaces. It's not going to be pinpoint. No? You're going to see maybe vessels, a circulation, or maybe patches of hyperfluorescence corresponding to the caverns and the choroid. And then what happens is you're going to get a huge hyperfluorescence coming from it. Extensive hyperfluorescence. فيما بعد, you get what we call a washout. So the hyperfluorescence quickly disappears, that leakage quickly disappears. You have a little bit of staining that remains within the tumor, and then you have a hypofluorescent ring
Around it.
around.
Yes.
That's the washout. Okay? So this is absolutely not going with.
Exactly. For the first impression depended on the B-scan only, and the B-scan ultrasound technician report.
I'm just gonna jump in here and tell you. So what basically happened is that this patient came at the end of the duty. They only had the chance to do B-scan.
Yes.
And then when the resident saw him in the ER, he had the impression that this is an RD.
Right.
And he referred it to surgical retina. Okay. And then he went, the patient went, she had the B-scan, and then the technician said she had a lesion in the choroid.
Right.
So then the thought was that she had probably a choroidal lesion with the secondary oxidative RD, and the thought was that maybe it's a case of circumscribed choroidal hemangioma as one possibility. And then when the patient came and had the fluorescein and the follow-up, she was shown to have this florid picture of hot disc and the oxidative RD, and she started to get some activity in the other eye, and then everything was obvious. So the point is, what I was trying to show in this case is that always to make an assumption that this is a rheumatologist RD, you'll have to have a clear break and the behavior of an RD that rheumatologist is different. And then when you see a clinical, like a finding on B scan that says a lesion, you have to investigate that and look into it very clearly before, yeah.
Exactly. Yes, Doctor. Thank you. تفضل دكتور. We don't have صراحة ICG for that. I tried to find the A scan.
Unfortunately, it was not done.
It wasn't done, honestly. What we have in tracker, I put it in the slides. You will see it all. تمام.
Okay, let's try to jump as fast as we can because it's about to.
Sure.
We are about to pass the time. We still have 2 more presentations.
The diagnosis is made as VKH. So VKH stands for Vogt-Koenigsegg-Harada syndrome. It's an uncommon multisystem disease of presumed autoimmune etiology characterized by chronic, bilateral, diffuse granulomatous panuveitis with accompanying integumentary neurological and auditory involvement. The epidemiology, the incidence varies geographically, accounting for up to 4% of all uveitis referrals in the US, 8% in Japan. In Brazil and Saudi Arabia, it's the most commonly encountered cause of non-infectious uveitis. The etiology is unknown, but current clinical experimental evidence suggested cell-mediated autoimmune process that T cells are against the melanocytes, self-antigens against the melanocytes of all organ system in genetically susceptible individual. These genetically susceptible individual, there is a strong association between HLA-DR4 in Japanese patients and HLA-DR1 and DR4 in Hispanic patients in Southern California. Stages of VKH, we have prodromal stage 1, stage 2 acute uveitic, stage 3 convalescent, and stage 4 chronic recurrent. The prodromal stage, usually the clinical signs and symptoms, flu-like symptoms, non-specific, headache, nausea, meningismus, fever, tinnitus, orbital pain, photophobia. The acute uveitic stage, what our patient has, blurred vision after 1 day or 2 days of CNS signs, bilateral granulomatous anterior uveitis, vitritis, thickening of the posterior choroid with elevation of the peripapillary retinal choroidal layer, hyperemic disc, or hyperemia and edema of the optic nerve, multiple serous RDs. The convalescent stage, stage 3, usually occurs several weeks later, and we will see clinically resolution of oxidative RD, gradual depigmentation of the choroid, resulting classic orange, red, or what we call it sunset glow fundus, perilimbal vitiligo or Segura sign, integumentary changes, skin changes, vitiligo, alopecia, and poliosis, which appears weeks or months after. These are some images of the sunset glow fundus, Segura sign, and skin changes, vitiligo, and poliosis. Chronic recurrent stage, the 4th one. We have clinical signs and symptoms, repeated granulomatous anterior uveitis, KBs, posterior synechia, iris nodules, iris depigmentation, stromal atrophy, and posterior segment recurrence, usually uncommon, like vitritis, papillitis, multifocal choroiditis, ERD. Visually debilitating sequelae of chronic inflammation, including cataract, glaucoma, CNV, subretinal fibrosis. Okay. The revised diagnostic criteria of VKH, they divided the VKH in 3 forms: complete, incomplete, probable. This is exactly the revised criteria.
But in order to diagnose a patient, you need to diagnose VKH, it's only clinical. So if you have the first three, it's VKH. So it has to be the first three categories. Number one, no history of penetrating ocular trauma. Number two, no clinical or laboratory evidence of other ocular systemic disease. And number three, it has to be bilateral. Plus neurological tinnitus, meningismus, or integumentary skin changes. So incomplete criteria 1, incomplete for VKH, criteria 1 to 3, and either 4 or 5. Probable VKH, criteria 1 and 3, and from the above, and must be present. Okay? The treatment, the mainstay therapy of VKH is corticosteroids. Oral versus IV routes of administration shows no demonstrable differences in VA outcome or the development of visually significant complications. For patients intolerant of systemic therapy, we use intravitreal corticosteroids. Systemic corticosteroids are tapered slowly according to the clinical response, on average of over 6 to 12 months period. And the risk of recurrent inflammation has led many experts to initiate immunomodulatory therapy like Celicept, infliximab, and etc. earlier to achieve more prompt inflammatory control to facilitate more rapid tapering of corticosteroids. Take-home message, do not depend on B-scan reports. If there is an RD in one eye, always check the other eye. Thank you very much. My references are American Academy of Ophthalmology. Dr. Sarah?
For this presentation. Yeah, you can proceed, Dr. Sarah. Okay. If you have any questions, I think we can keep them to the end because we're already, we still have 2 presentations.
Assalamu alaikum wa rahmatullah. My name is Sarah Al-Hilali. I'm an R2. Thank you, Dr. Adil, for supervising me during this case presentation. Our patient is a 53-year-old female known to have diabetes for 20 years, which is uncontrolled. She presented to our emergency department with 1-month history of painless drop in vision of the left eye. Her past ocular history is insignificant, no previous history of PRP or any anti-VEGF injections. The examination of the right eye was within normal. The VA was 20/30, IOP within normal. The entire exam was within normal anteriorly, except for posterior subcapsular cataract. The left eye examination showed a vision of 1/200, IOP within normal. The rest of anterior exam is within normal, apart from an APD and the presence of an NVI and posterior subcapsular cataract. This is the fundus photo of the right eye. I think it's not clear by the pictures. However, it showed the NPDR. A part of that, it was within normal. The fundus photo of the left eye showed vitreous hemorrhage, multiple TRDs as apparent by the photo. This one is threatening the macula. So the plan was to do PRP for the right eye and intravitreal anti-VEGF and PPV membrane peeling and SF6 for the left eye. Day 1 post-op, there was no active complaints. However, in the examination, VA showed NLP vision, IOP of 30, conj was quiet with no leak, clear cornea, AC deep and quiet, and the APD and the MVI were present with the posterior subcapsular cataract, and the fundus was flat under more than 90% of gas. So what strikes you as abnormal in this examination? The NLP vision. So it's uncommon to have NLP vision post-PPV. So what explains NLP vision in the left eye in this case, post-vitrectomy? I've divided them into preoperative, intraoperative, and postoperative causes. So what could you think of preoperative causes of that would lead to NLP vision in the left eye? 53. Anesthesia complications, intraoperative causes. Okay, also the inducing a retinal break, macular hole, post-operative, no light perception, yeah. Yes. What would it cause, the high intraocular pressure? Mm-hmm. Mm-hmm. True, correct. Reports have reported that actually face-down position and high IOP post-vitrectomy can lead to anterior ischemic non-arthritic optic neuropathy. Also, although it's not applicable in this case, but we should think about choroidal detachment, choroidal hemorrhage, and so forth. So day 3 post-op, the patient started to complain of drop in vision in the right eye. So the examination of the right eye was hand motion. If you remember, she was 20/30 vision. IOP 18, quiet conch, clear cornea, AC deep and quiet, reactive pupil, posterior subcapsular cataract, and the fundus showed combined TRD and RRD. Unfortunately, there's no fundus photos for this patient. The left eye exam was the same with the NLP vision, and the IOP was controlled at that time. So now, what explains the RD in the right eye? She had an injection in the left eye preoperatively. It could be the.
This was very interesting. It was a very, a bad sequence of events that happened to her, and there is no really a clear explanation. But the patient actually had the TRD extramacular in the right eye, and before the PRP. No, it was extramacular. It's not shown in this image. But basically, what the thought was that whether it's a progression related to the PRP that happened, and then she developed this break, or probably a systemic effect from the anti-VEGF that was given to the other eye. And this is what we're trying. I think Dr. Sara is going to.
So as Dr. Adil mentioned, it can be part of the natural history of diabetic retinopathy, or what we're thinking in this case is the contralateral effect of anti-VEGF. Just to sum up the conclusion of the case, she underwent PPV and membrane peeling and silicone oil in the right eye. Her follow-up in the clinic showed a vision of 2300 in the right, and the retina was flat under silicone oil. The vision slightly improved in the left eye for 2/200 with flat retina with small gas bubble. So now, what are the contralateral effects of intravitreal anti-VEGF? Now, studies have reported that conducted studies on rabbits showed that Avastin was injected unilaterally through an intravitreal route in eyes of rabbits, and the levels were measured in the vitreous and the serum, which were raised to a lesser extent in the contralateral eye. So this suggests systemic absorption and distribution, and by logic, it means whatever effect you are exerting in the injected eye, whether it was positive or negative, it can happen in the contralateral eye, even if it was to a lesser extent. So this is the positive effect of unilateral anti-VEGF. This study showed that more than a quarter of patients experienced a reduction of 450 microns of the central macular thickness in non-injected eye, and more than a third showed 410 microns reduction in the central subfield thickness. So there is a positive effect of anti-VEGF in the non-injected eye. However, what happened in the patient is a negative effect, which is a progression of the TRD in the contralateral eye. This is also a case report that reported a patient receiving anti-VEGF in one eye and progressing contralateral macula of TRD, as what happens with our patient. So the take-home message is NLP vision post-PPV is uncommon, so detailed examination to rule out other serious causes is mandatory. Avastin has been linked to the development of tractional and rheumatogenic retinal detachment in the injected eye. Therapeutic response of intravitreal injection of Avastin on the contralateral eye has been reported in the treatment of PDR and macular edema. This suggests adverse effect should also be anticipated in the contralateral eye. It has been reported to cause progression of TRD involving the macula and the contralateral eye. Thank you.
Yeah. Thank you.
أحتاج يفصل
وريني. It's here.
Yeah. Thank you.
Can we put this way so we're not putting down?
Yeah, okay.
Are you gonna using your
Yeah.
remote control?
No need.
Okay.
Okay, my presentation is titled The Great Imitator. A 37-year-old gentleman presented to the ER, not knowing having any other medical illnesses, not on any medication, presented to the emergency room complaining of painless, blurred vision in the right eye for the past 3 weeks. On examination, the anterior segment was unremarkable. Visual acuity was 20/20 both eyes. IOP was normal both eyes. And this is the fundus examination that he presented with. On examination of the right eye, there is whitening over the macula, especially at the superior area, with suspicious hemorrhage inferior to the macula. The left eye was unremarkable with some defects. That's because of the photo. On FFA, he had an early hyperfluorescence at the macula, especially at the superior side with normal FA zone. And it continued to stain until later on. The patient was treated elsewhere for BRAO, so he was referred to KKESH as BRAO at an age of 37, and he had this inferior visual field defect in the right eye, sorry. On the differential diagnosis, basically for BRAO in a young gentleman, is collagen vascular diseases, including systemic lupus erythematosus, polyarthritis nodosa, and other hypercoagulable disease, trauma, and the rare causes are migraine, Behçet disease, and syphilis, and sickle cell disease. And in the while Dr. Adel digged in the history, he asked about social history. The patient appeared to be a social drinker and a heavy smoker, also had multiple sexual partners. So he had a laboratory test for uveitis, including ANA, rheumatoid factor, and rapid plasma regain, and syphilis TB antibody. And he turned out to be positive for RNA and reactive for both the rapid plasma regain and syphilis TB antibody. So I'll be talking about ocular syphilis. Syphilis is a multi-system chronic bacterial infection caused by gram-negative spirochete Treponema pallidum. The disease most often transmitted during sexual contact. Congenital syphilis is transmitted through placenta. The most common finding of syphilis is uveitis, occurring in 2 to 5 of patients in tertiary syphilis and 1 to 2% in all uveitis cases. Primary syphilis follows an incubation period of approximately 3 weeks, and this is the duration of period that the patient presented. They are associated with a chancre, which is a painless solitary lesion that originates at the site of inoculation, resolving spontaneously within 12 weeks. Secondary syphilis occurs 6 to 8 weeks later and is heralded by an appearance of lymphadenopathy and generalized maculopathy rash, may be prominent on the palms or soles. Approximately 1/3 of untreated patients develop tertiary syphilis, which can be divided into benign localized granulomatous reaction, or a gumma, a severe diffuse inflammation involving primarily the cardiovascular and central nervous system. Ocular syphilis may be presented in a wide variety of inflammatory manifestation, reflecting the status of the great imitator. The ocular inflammation may be unilateral or bilateral and may affect the anterior and posterior. Anterior uveitis may be granulomatous or non-granulomatous and may be associated with iris, rhesiola, vascularite papules, large red nodules, and gummata. Other findings include episcleritis, scleritis, interstitial keratitis, posterior synechiae, lens dislocation, iris atrophy, basically everything. A syphilitic posterior placoid chorioretinitis has been described, which is a clinical appearance of angiographic characteristics that are thought to be pathognomic for secondary syphilis, which is a solitary multifocal macular or papillary placoid, yellowish gray lesions at the level of the retinal pigmented epithelium, often with accompanying vitritis, displaying correspondence to early hyperfluorescence and late staining along the retinal perivenous staining on fluorescein angiography. And this is the chorioretinal placoid, as seen early hyperfluorescence and continuing staining later on. This picture was taken from Dr. Tabara's book on ocular infection. Patients with acute syphilitic posterior placoid or chorioretinitis show characteristics of outer retinal abnormalities on the OCT, including disruption of the inner segment outer segment band, nodular thickening of RPE with loss of linear outer segment RPE junction, and in some cases loss of external limiting membrane, accumulation of subretinal fluid, and punctate hyperreflectivity in the choroid. Syphilitic uveitis can also manifest in retinitis without choroidal involvement, involving the posterior pole and periphery. Syphilis can also present with necrotizing retinitis in the mid-periphery and peripheral retina and may resemble an acute retinal necrosis or progressive outer retinal necrosis. An isolated retinal vasculitis that affect the retinal arterioles, capillaries, and large arteries and veins, or both, in another feature of syphilitic intraocular inflammation, which has been presented in our patient. Focal retinal vasculitis may masquerade as a branch retinal vein occlusion. Neuro-ophthalmic manifestation of syphilis, which is tertiary syphilis, are agral Robinson pupil, ocular motor nerve palsies, isolated papillitis, optic neuropathy, neuroretinitis, retrobulbar optic neuritis, and the list go on. Progressive visual loss secondary to optic atrophy may be seen in manifestation of tertiary syphilis. So the management of ocular syphilis are 18 to 24 million units of aqueous crystalline penicillin G per day, administered as a 3 to 4 million units intravenously every 4 hours or as continuous infusion for 10 to 14 days. Ocular syphilis may be treated with 2.4 million units per day of intramuscular procaine penicillin plus propincid 500 milligram 4 times a day for both for 10 to 14 days. In penicillin allergic patients, we can who do not show any neurosyphilis signs and who are HIV negative, we can use doxycycline. And patients who are who have positive neurosyphilis, we can use ceftriaxone 2 milligram IV or IM. So back to our patient. Patient reports improvement of symptoms 3 weeks after presentation with proper management elsewhere. And this is his fundus photo later on. And this is the autofluorescein showing the placoid. And this is the other eye, which is normal, so it's unilateral. And this is the autofluorescent. This is the OCT, which is, it wasn't taken before treatment, but he had a good 20/20 vision. And this is the visual field after on. Thank you. Three weeks. Oh, okay. Of what? No, only this. Only it was, he was sent as a BRAO. This whitening, yeah. Well, it's in the superior, so we're gonna appear inferior. أيوة. Yes, yeah. Yeah.
Thank you everybody. شكرا ريم ودكتورة سارة وحمود. خلاص, by this we conclude the meeting.
Thank you, everyone. You can watch the review at 9 o'clock tomorrow. Dr. Mohammed Ratib is speaking.